it on the last Saturday. And I welcome President Delhi Orthopaedic Association, Dr. Sharad Agarwal, Dr. Hitesh Lal, and also last time we had Professor Meena and Atul Srivastav. So this time we will not waste time on the inauguration, so we will continue. So I request Dr. Sharad to start the proceedings, and please, Dr. Sharad.
Thank you, Dr. Manish. Dignitaries from the Indian Orthopaedic Association, Dr. Rajesh Malhotra, past President IOA and Organizing Chairman of MIDCON 2020, Dr. Manish Dhawan, Treasurer IOA and Conference Moderator, the eminent international and national faculty of MIDCON 2020, Executive Committee and all members of Delhi Orthopaedic Association, delegates and friends. On behalf of Delhi Orthopaedic Association, I welcome you all again to MIDCON 2020, which is the mid-year conference of Delhi Orthopaedic Association. To fit in the present day scenario, the virtual conference has been divided into two segments, and today we are having the second part. Conventionally, the DOA MIDCON is dedicated to the subject of trauma, and this year's theme is Fragility Fracture, a subject which is very relevant to present day health concerns. Today's segment is dedicated to fragility fracture of spine and lower limbs. In elderly in particular, the age group in which such fractures are most common, fragility fractures can lead to increased risk of mental and physical problems and a significant decrease in mobility and quality of life. Hence, quick and effective remedial measures are necessary in these subjects, in these cases, which have their own unique challenges. To deliberate on these subjects, Dr. Vijay Sharma, the conference convener, has invited a galaxy of illustrious international and national speakers. Besides discussion on orthopedic management, we have an eminent speaker, Dr. Mittal, to share with us the medical management required in these cases. It shall be a great learning for all of us, and I'm sure we all shall be a lot wiser about the subject after the conference. Thank you.
I'll also like to thank Dr. Ashok Sham, Dr. Neeraj Bijlani, Dr. Shamshul Huda, and Dr. Ravi Chauhan for providing us the technical support and making this possible. Over to Dr. Vijay Sharma to please introduce the faculty. Dr. Vijay.
Thank you, Dr. Manish. Good evening, respected seniors and dear friends. And on behalf of DOA, I a warm and hearty welcome to all the distinguished international and national speakers to this MIDCON 2020. So it's a great pleasure for me to introduce Dr. Ambrish Mittal, who is the opening batsman, and he does not need any introduction. He's everyone knows him. So he's a recipient of prestigious Padam Shri and BC Roy Award. Presently, he is chairman and head of the department endocrinology and diabetes at Max Healthcare, Saket and Gurgaon. He was the first DM candidate from AIIMS in 1987 and the past president Endocrine Society of India. So I think I invite Dr. Ambrish Mittal for his very important talk on post-fragility fracture evaluation and medical management. Over to Dr. Ambrish Mittal, sir.
Are the slides visible?
Yes, sir.
Yes, thank you.
Yes.
Thank you very much for the kind words. It's always a pleasure to be back here amongst orthopedic friends, and a lot of my life in the last few decades has been spent with orthopedic friends, because my area of interest has been osteoporosis, vitamin D deficiency, bone disease and hyperparathyroidism, etc. And it's a real pleasure to be here. And today, very briefly, we'll talk about post-fragility fracture evaluation. So we're not talking of preventing the first fracture. We are talking straight away about capture the fracture and prevent the second fracture or the third fracture, as the case may be. So what should we do in someone who comes to us with a fragility fracture, which is what you deal with? You are the guys with the golden hands, you fix all their trouble. But the issue is that what should be done after that fixation, after that treatment. So, So the first thing that we all know very well, you know the morbidity and mortality of vertebral and hip fractures. To keep the slide really low, I have not gone there. But it is very important to understand that even if you do a fantastic job of fixing a vertebral fracture, the risk of a vertebral fracture is very, very high following that. And if someone X-ray shows multiple vertebral fracture, then you've done whatever you had to do, surgery, conservative, whatever. The issue will remain that even though you've done that, the risk of fractures is very high. So If someone presents with a vertebral fracture, there's a 20% chance of getting another one in the next 1 year. And if the number of baseline vertebral fractures is high, like the multiple fractures, then the risk is even higher. So the thing we have to remember is that unlike traumatic fractures, fragility fractures reflect a systemic disease. And the vertebral fracture that you see is a manifestation of a systemic disease. I would, for physicians, I always explain it's like getting an angioplasty done. If you or your parents or somebody in the family has had an angioplasty, you have fixed that block, but you have not fixed the disease per se, and more will happen unless you take adequate. Oh, someone's sound. So it still does not mean that you have done a good job, although it may be very, very good surgically, unless you take measures to reduce systemic measures. You will
Please
not.
mute.
How can I?
Please mute Harmesh. This is Harmesh.
ओपन Zoom मीटिंग करो
Mute everybody, please.
पासवर्ड डालना पड़ेगा हो जाएगा
Harmesh, mute yourself.
There's too much background sound. Doesn't matter. It happens in webinars. We can just.
Harmesh, can you Harmesh?
हेलो
Harmesh, mute करो अपने आप को.
सॉरी सॉरी मैं कर रहा हूँ कि वो डिस्कनेक्ट हो गया था
Okay, thank you so much. So it's important to understand, and I will quickly repeat that if you or someone in your family has had an angioplasty, that's fantastic, or a coronary artery bypass surgery, but unless you take statin and aspirin, etc., after that, the job is not complete. Because it's a systemic condition, so is osteoporosis, and that's how we have to look at it. And we also know that hip fracture has high mortality. And many of my colleagues, when I started talking about this 20 years ago, refused to believe me. I said, our patients don't die. They come on a stretcher and they go out walking, which is completely all right. But it does not necessarily mean that they continue to be like that for 1 year or 2 years. The problem with hip fractures is that 20% patients of hip fracture die within 1 year. Worldwide data. This is an IUF slide. The figure is higher in India, definitely. Or they have permanent disability, all those things. So this is very obvious. The thing is that you need to therefore intervene to reduce these risks that you're talking about. This should be as flat as possible, right? So we should try and see if we can do anything about that, like in vertebral fracture. So there are 3 studies from India. I think one from Maulana Azad, one from AIMS, and one from PGI, all showing similar results. But this is the first one, so I put that in there, where they looked at 90 patients followed up telephonically at the end of 1 year. 14 were lost to follow-up, but 28 out of those 90 had expired. Okay, and sometimes as surgeons, not being used to chronic care and being fixers, like trying to fix things all the time, we lose sight of the fact that what happens to the patient after that. It's not even your job, but I'm just saying that this is what happens. So therefore, initiating therapies that will reduce this is actually very, very important for us. I'm not going into laboratory details, but I would just say that at least measure a calcium, vitamin D, PTH, which all of you do, but still we get cases from the periphery and others where you've had a surgery and not a serum calcium measured. I mean, even last month I had a case like that. So it's important to look at the metabolic abnormalities. I'm not going to a full flow chart of what happens if you find what, but the truth is you have to rule out hyperparathyroidism. You have to rule out, multiple myeloma. All those, one screening test, one sort of test for all these is important. And I would say you always do KFT, LFT, obviously. That should include calcium also, ideally. You should do a PTH, a TSH, a vitamin D. Till this level, everyone should have the tests. The last 3 is dependent on what the patient presents with. You need not do it in everybody, but if you have any suspicion, then the last 3, that is electrophoresis, TTG antibody, and overnight DEX suppression, only if there are clinical symptoms or suggestions. The rest have to be done for everybody. This is an important part of evaluation. Sometimes you forget that. These are, as I said, these are not mandatory. These are dependent on clinical systems. So what do we do once we've done that? And let's not talk about lifestyle. You will give all instructions about that. I'm talking purely of choosing drugs. What are the drugs we have? Anti-resorptives, bisphosphonates. We have hormonal therapy, estrogen, which we'll leave out because we're hardly using that. So bisphosphonates is important. Denosumab is very, very important. So anti-resorptives for us means bisphosphonates, denosumab. Anabolic agents, we only talk of teriparatide. Right now, we don't talk of abaloparatide, or we don't also talk of romosozumab, which is a very interesting anabolic agent. But we are now limiting ourselves, therefore, to 3 molecules. I'm trying to simplify as much as possible. 3 groups of molecules: bisphosphonates, denosumab, teriparatide. Right? And of course, the calcium, vitamin D goes along with that, no question. So it's just important, one line to remember, that vitamin D in India is often low, especially in urban India, but we should not go for overkill. Typically, we want levels of above 20, maybe even above 30 nanograms. And if we give somebody 2000 units a day, if we, some distraction again, I'm sorry.
Vineet Arora this time.
So if we give somebody 2000 units a day of vitamin D, by and large, we are able to maintain normal vitamin D levels, which means 60,000 units once a month. There is a tendency to use very high dosages, which is not recommended. Injectable vitamin D is not required by and large. So injectable, now I'm talking of 2000 IU per day, where international recommendation is 1000 or 800. I'm talking of 2000, which is still high. And if you are giving an injection of vitamin D, that contains 600,000 units of vitamin D. So you understand what I'm saying? There is a gap. There is a good safety margin, but we are stretching it these days, and people are overusing vitamin D. Use the correct dose in the correct patient. You need to use little higher in people who are obese or whatever. We can, but broadly speaking, if you're using 2000 IU per day, you're keeping your patient safe. If patient clearly has been demonstrated to have very low levels, you may give that weekly regimen of 60,000 for a few weeks and then make it 60,000 once a month, or 2000 IU a day. And that's an important point. What about bisphosphonates? Bisphosphonates are osteoclast poisons, and they will knock out the resorption activity. You know that better than I do. And I won't waste your time, just to remind you that zoletonic acid intravenous given once in 12 months has a remarkably successful effect on reducing both hip fracture and vertebral fracture. And if you can see, most therapies, they are a little weak when it comes to hip fracture, but intravenous denosumab is fantastic, 5 milligram given once a year, and it works very well for both 70% reduction in morphometric vertebral fracture, 25% in non-vertebral overall, and 41% reduction in hip fracture. So that's huge. So if you're discharging your patient, probably at that time itself, if you give a 5 milligram infusion of zolatonic acid, you'll probably be doing a great service, because you've done something for 1 full year, or maybe even 14, 15 months, you've taken action for that patient. There are safety issues with bisphosphonates. You'll ask about osteonecrosis of jaw, atypical fractures. We've all seen atypical fractures, but osteonecrosis of jaw is exceptionally rare. Very, very rare. And one should not worry too much about it if you use the correct dose. Okay. If someone has a dental work that is pending, get that done. Otherwise, you don't have to worry too much. Atypical fractures happen typically when we've used them for long and in high doses, and that is possible, and that usually happens when patient is on concomitant steroids and other things. So we will leave that for the present. But a mid-shaft fracture that happens suddenly in someone who is on bisphosphonate is an atypical fracture, and it's a known thing, not common, but it's known. Now, if you look at osteonecrosis of jaw, and people say, "Oh, jaw is very dangerous." This is a very telling slide. Mike Levicki made this slide, and if you look at any fragility fracture, hip fracture risk, right? And if you look at the ONJ risk, osteonecrosis 0.7. If you look at death by murder, it is 6. If you look at death by motor vehicle accident, it is 11. This is American data, and I think motor vehicle accident deaths will be higher in India. You guys deal with them all the time. What I'm saying is death by lightning, it's almost the same. So let's be real about the side effects, and let's not, unnecessarily worry. We should know, we should be aware, but they are not common. Quickly coming to teriparatide, which is an anabolic hormone. You know that the main thing with teriparatide is it's given once a day as a shot for 18 to 24 months, not for 2-3 months. Don't do that. 18 to 24 months. And now you have so many generic forms available in India, it's not even that expensive. So tell your patient it's going to be long-term before you start. We don't typically go beyond 2 years. We go as a daily, like a pen, like insulin for us is very easy for patient to take. And it is specifically good for vertebral osteoporosis, spinal fractures. It's the most powerful agent known for vertebral fractures. The data on hip fracture and teriperitide is largely extrapolated data. Large enough trials are not available to convincingly show benefit on hip fracture. We think it is beneficial, but it's more on modeling and statistics rather than hard patient data. And you can see, you love to see this QCT reconstruction, pre-teriperitide and post-teriperitide. I mean, it's such a telling picture. It says everything. Not every patient, let me tell you, responds this well, but this is, of course, a prototype of how the response can happen in this case. And it reduces fracture risk, new vertebral fractures very significantly, non-vertebral also, but if you look at hip alone, you don't have enough data. However, it is used for that purpose also. It's not that it's not effective. We just don't have large enough numbers in our studies to close that out. Coming to the third drug that we were talking about, denosumab, which is relatively new in India, a couple of years. It's an anti-resorptive given as a sub-Q injection every 6 months, right? So we have 4 types of drugs. I mean, 2 of one type. One is the oral bisphosphonate, which we know is given once a week or once a month. We have the intravenous bisphosphonate, and post-fracture, typically we go for intravenous bisphosphonate. And I'm not going to do side effects and everything, but an acute phase reaction can be there, flu-like reaction, slight rise in creatinine, but usually they're all temporary. So that is one. Then you have the second group of teriperitide, which is a bone-forming agent, PTH. And the third is denosumab. Now, what does denosumab do? It acts actually, this is the denosumab molecule, the blue star-like things, okay? There's a crosstalk between osteoblast and osteoclast. So the osteoblast makes rank ligand, which is this blue star-like thing, which binds to the red receptor, the rank. So rank ligand binds to rank receptor. These yellow denosumab molecules, they capture the rank ligand, don't allow it to attach to the rank, right? So you're interrupting the crosstalk between osteoblast and osteoclast. What happens is that while osteoblasts continue to function, the osteoclast function is cut off because the signal doesn't reach them from osteoblast. So osteoclasts that are bone resorbing cells, their function gets impaired. Whereas osteoblasts that are bone forming cell, their function is not so severely impaired. So as a result, less osteoclasts will be formed, and if formed, they're less active. Unlike bisphosphonates, which kill preformed osteoclasts. So bisphosphonates, like you take an army and you kill all the osteoclasts, right? Shoot them down. With denosumab, you don't allow the opponent's army to reach the field at all. You're preventing it. You're blocking it in the way, right? So that's how there's a difference between these 2 drugs. Denosumab also works for both vertebral and non-vertebral fantastically, and also for hip. So it's an amazing molecule. 6 monthly, just a sub-Q shot. You can see the reduction in 70% reduction in vertebral, non-vertebral overall, and hip. You can see hip also is reduced. Last couple of minutes, we've understood that there are 3 broad options for us available. One is Zolatonic acid, intravenously once a year. Second is teriperitide daily sub-Q for 2 years. Third is denosumab 6 monthly subcutaneously. But how long should we treat? And that's very important for surgeons, because surgeons are not used to chronic care, whereas all that we do, 80% of what we do is chronic care. And osteoporosis, like it's a systemic disease, it's also a chronic long-term disease. Okay, so is prolonged treatment safe? Yes, prolonged treatment is safe. By and large, people with significant or severe osteoporosis require some form of treatment throughout their life. Again, like blood pressure, diabetes, cholesterol, same way. Okay, it's not that the fracture is fixed and they're okay. So when you look at alendronate, and when you continued it for 10 years, it was quite safe. Okay, 5 years alendronate followed by placebo or 5 years alendronate followed by alendronate, well, 10 years alendronate. And you can see in the 5 years where alendronate was given, in the second 5 years, and other group was given placebo, there was significant reduction in, say, vertebral fractures in the alendronate group. So it continues to work. Zolatonic acid, alendronate, of course, is once a week. Zolatonic acid is the one I've been talking about, once a year. And you can see when you go from 3 to 6 years, if you extend your treatment annually 3 years to 6 years, you still continue to significantly reduce. Look at the right side of the panel, fracture risk. So not only does it work for 3 years, it can go for 6 years. And even at the end of 6 years, from 3 to 6 also, there is difference in fracture rates between Zol group and the other group. Message from this is oral bisphosphonates, there is data for up to 10 years or even longer now, people are saying. And intravenous bisphosphonates, there is data for up to 6 years. So what should we do? What about denosumab? Last point. Denosumab, we know, continues to work. It is safe for long-term use. And in the extension study, we see that denosumab continued to reduce fractures. Look at this. Continue to reduce fractures for 10 years of therapy. So you don't have to stop it at 2 years, 3 years. If required, it can be given for 10 years. And there is data, people are telling me anecdotal, which is longer than 10 years also. So teriparatide, 2 years. Oral bisphosphonate, 5 years or maximum 10 typically, but you can go longer. Intravenous bisphosphonate, you don't go beyond 6 usually. You'll do for 3 years, maximum you can stretch to 6. And denosumab also can go on probably indefinitely. Then how long should we treat? How do we decide? What do we do? For treatment with bisphosphonates, you want to consider a drug holiday after 4 to 5 years. Everything is a little empirical here because it's not 100% proven. But this is the standard being followed. Typically for intravenous at 3 years, you give a stop and reassess the patient for fracture risk again, all the tests, and then decide whether the patient is still at high risk. You can go up to 6 years. With oral bisphosphonate, you reassess in 4 to 5 years. Again, if patient is still at high risk, you can go up to 8 or 10 years, right? So if the fracture risk is high, you will give a drug holiday after 10 years. You can go straight for 10 years in oral. And of course, how do you decide? Of course, you will do a bone density. And when you're following up a patient, when you've withdrawn the drug, you have to use bone density and bone turnover markers both to decide whether the patient needs to go back on treatment or not. So supposing I have taken intravenous bisphosphonate for 3 years. At the end of 3 years, you do a bone density on me and my risks are still high. Other factors are still high. You may continue it for 6 years. Okay, 3 more years. After that, you stop. But then when you stop, every year you will call me, you will check a bone density, you will check bone turnover, you will check the biochemical parameters. And if you find I'm escaping, you will restart the therapy then and there. The problem, however, is that despite all these things, overall use of medication for osteoporosis is going down. Well, it's actually a little improving. This is 2014. The peak use of osteoporosis medication in the US was around 2002-03. After that, because of doctors being scared of so-called side effects, which are exceedingly rare, and patients, because media wrote such bad things about molecules, there has been a decline in therapy. This is 2014. It is again picked up now. But overall, there is a reluctance to use osteoporosis medication, which is not justified by any science. And then in New York Times, this 2016 came out with another opposite article, fortunately. Gina Kolata is a very influential writer, saying that fearing drugs' rare side effects, millions take risk for osteoporosis. Which is not right. And then messaging changed. And now people are much more willing to go on bisphosphonates than they were about 3-4 years ago. But there was a period when the media was bombarding you with information about the adverse impact of molecules, and therefore it went out. Again, I would say, I will use a simple example because even if you're not treating such patients directly, it's the same thing about statins. The noise about statins in the media is so much that so many people who are ideal candidates for statins have given them up and actually have suffered heart attacks as a consequence. Last slide. What's my take-home message? For hip fracture patients that you treat, IV Zolatonic acid at the time of discharge, 1 day or 2 days before discharge, is a very good practical regimen. The Indian Society of Bone Mineral Research is going to come out with a recommendation for all surgeons that when you are discharging a hip fracture patient, of course, provided there's no contraindication, you should give an infusion of Zolatonic acid. For 1 year, your mind is then, at ease. And we also know that Zolatonic acid action spills over to 15 months, 16 months also. So patient is a little late in coming back, doesn't come in 1 year, comes back in 15 months, 16 months, it's still manageable, right? The second choice in that, if patient doesn't want to use that or that's contraindicated, denosumab works very well for hip fracture. So you can start the patient on denosumab 6 monthly shots. The problem with denosumab is that you have to be very compliant. The injection has to be taken every 6 monthly. Because if you stop denosumab suddenly and you don't give any other medication to cover up that period, there is a relapse, there is a rebound risk of fracture. Okay, so patients on denosumab have to be given 6 monthly denosumab. And if you think the patient is not likely to be compliant, or you won't send reminder, don't have a system, then don't use denosumab, use Zolatonic acid. Because if someone takes a denosumab injection, I'm having that problem because of COVID in December and it's due in May. You cannot delay it beyond June, maybe 1 month, but beyond that, if you go, it starts escaping very quickly. Vertebral fracture is important. Teriparatide is the most powerful agent for vertebral fracture. It builds bone. It's an anabolic agent. If patient comes with multiple vertebral fractures, teriparatide is a good option for 2 years. But teriparatide has to be followed by an anti-resorptive, one of the two that you saw here. You can't give 2 years teriparatide and let the patient walk on the street. You have to say that this is going to build your bone, but you need some maintenance for your bone. And for that maintenance, you have to use an anti-resorptive drug, which could be either intravenous Zolatonic acid or denosumab. I think that is an important message. And if these are not there, at least an oral bisphosphonate has to be started. So teriparatide, you build the bone, but to keep the advantage, you need to continue therapy with other drugs. Of course, for vertebral fractures also, you can use Zolatonic acid very well and denosumab. So IV Zolatonic acid and denosumab work for both groups of patients, vertebral and hip. And if you have a severe case, and this is still not a clinical recommendation, but a very severe case, very low T-score, multiple fractures, already has had on and off treatment, then you may consider combination therapy. Combination therapy, the best is teriparatide plus denosumab, which means teriparatide daily and denosumab every 6 months. The advantage of this is a powerful combination. And if you look at bone density, the changes in bone density are very significant with this. However, we don't have any hard fracture data on this yet. But people are predicting and beginning to feel that this will be important. And therefore, as fracture data is being acquired, it's good to remember that it's not the first choice. It's not used in every patient, but like multiple fractures, repeated fractures, or very low bone density with multiple fractures, or very frail person likely to fracture again. In those imminent fracture risk patients, you can consider combination therapy. In general, a single drug is okay, and this is the order of preference. Denosumab has a fantastic role in switchover from any previous therapy. And it works very well regardless of whether the patient received teriparatide in the past or Zolatonic acid in the past or anything in the past. Denosumab will still work. So denosumab, therefore, is a very important second line therapy. It can be first line also, but in second line, it's perfect. And we must continue long-term management. Thank you very much.
Thank you, sir, for an informative, clear, and clinically oriented talk on medical management of osteoporosis.
There are no questions at present.
Vijay, can I ask one question, please?
Dr. Vijay?
Yes, of course.
Dr. Vijay?
Vijay.
Dr. Vivek,
There are
yes,
no questions
please
from audience, so you please generate the panel discussion.
Yeah,
I have a question in the chat box.
Yeah, shall I ask Dr. Vijay?
Yeah, please.
Yeah,
yes,
Dr.
Yes,
Amrish, thanks for nice presentation. I just want to know a few things, like is there any particular side effect of the denosumab which should prevent orthopedic surgeons to give this therapy on long-term basis? Secondly, how early in the fragility fracture after the fixation we can start this combination therapy or the individual therapy, which tells us which is not preventing the bone union.
Okay, so first is denosumab. Denosumab has the least side effects of all of them, definitely less than bisphosphonates, but the same side effects can happen. You can oversuppress bone turnover, you can get atypical fracture, you can get ONJ, but it is less than in bisphosphonate, right? So you can get those, but to be very honest, we haven't seen much of that as yet. And it's otherwise a very safe treatment. There is no reason for an orthopedic surgeon to be even slightly apprehensive of using denosumab. There is no question. The second is how soon after fracture can you start therapy, either single or whatever, but typically single drug. You can start it very soon. There is this fear about bone healing that has been repeatedly studied. And I can tell you with confidence, there is no reason right now to worry about that. You can give your denosumab or zoledonic acid soon after fracture. And my recommendation is your patient stays a few days in the hospital after surgery before you send them out, 1 day before that, so that if there's any reaction, you can see that also. You can start your treatment, not a problem.
Can I ask?
Thank you very much.
Yes.
Yes, Dr. Maheshwari, sir, yes.
Yeah, Dr. Amrish.
Yeah, hi.
Hi. So it is clear that teriparatide, if at all, is indicated. It is indicated only in vertebral fractures.
Okay, I'll qualify that question. It is not the drug of choice for hip fractures. There still might be patients who come with both types of fractures or others where you may want to use it. And it is probably effective in hip fractures also, but it is not the drug of choice. You're right.
Yeah, why I'm saying this is there is a big, hue and cry about teriparatide as being the last word in the word, last drug in the world to help with fractures. So and it's a difficult drug because it's expensive, long term.
Yeah.
So we should not be using it very casually. That's why I wanted to highlight this point.
So I think it's important, sir, that we don't use teriparatide casually. It is a very specific drug, and we have to make sure patient takes it at least 18 months, preferably 24 months. And it is not, that's why I said, what is ISBMR coming out with? We are coming out with a guideline for surgeons. Just give 1 infusion of zoledonic acid before you send your patient out.
Now, of course, everything has been worked on vertebral fractures and to some extent hip fractures, which are important for us as orthopedic surgeons. How about fragility fractures, inverted commas, upper humerus and distal radius? How serious should we take them as far as systemic therapy is concerned?
I think that's a great question. So wrist fractures typically appear, as you know, earlier in the lifespan, earlier in life course. Slightly younger people because they fall forward and they break their hip. When they're older, they fall backward, they break their hip. When they're younger, they fall forward and break their wrist. Wrist fractures are also a red flag. Treatment for osteoporosis should be initiated if it is a fragility wrist fracture. Some of them may not be severe and they may not require lifelong. As I said, you may be able to take them off in 3 to 5 years. But people who come with fragility fractures of the wrist should be treated with medication because they're already telling us that we have osteoporosis. You don't want to wait for the other bones to break. That is one. Upper humerus fractures, as you know, are now more or less part of the fragility fracture armamentarium. Although data is not there in terms of prevention exactly, but it is logical to think that it will work. Non-vertebral includes them. But now in osteoporosis parlance, upper humerus fractures are now more or less included as fragility fractures, as you said. So I would treat them the same way.
So Amrish, other concept we orthopedic surgeons carry is once the patient is 80, 85 years old, nothing works.
No. So that's a good question because there have been analysis of the very old, as they say. And there has been analysis of very old, both for bisphosphonates and for all three, actually. Not so much for teriparatide, numbers were small. But the other 2 studies had enough patients who were above 85 and the drugs are effective. Okay. You have to weigh the side effects and this thing, but the drugs are effective.
Can I ask a question, Dr. Amrish?
Of course.
Right. You said when you have treated a hip fracture and you're discharging the patient, you say you can start some anti-resorptive medicine.
Yes.
We need to take a baseline bone density at that time for future references, and then how often do we check the bone density in these patients? How frequently?
I think that's again a very practical and great question. Ideally, yes. I would want a bone density because that's one of the ways we monitor follow-up. But sometimes people say bone density में दिक्कत है, कहाँ करेंगे, क्यों करेंगे, ये वो. So fracture itself is an indication for treatment. So there's no question about treatment. But for long term, I would want a bone density to be done, a DXA of hip and spine, and I would repeat it 18 to 24 months. Sometimes we do it annually, but not earlier than 1 year for sure in follow-up.
Can I
Okay,
ask?
I think let us, yeah, Dr. Vivek.
Yeah, Dr. Mittal, very nice presentation as always. Wanted to know that you were very firm on saying that teriparatide is given for 18 to 24 months.
Yes.
And it has to be given at a stretch.
Yes.
So, because if you have to give, it's a 20-over match and we have to give it 20 overs in a lifetime. So can we use 5 overs and then use it and combine it with denosumab to extend the thing? Or it has to be used for minimum of 12 to 24 months? Or
so the concept you're describing is actually fascinating. That's what studies are trying to look at. That you use 6 months anabolic, then you use this, but it's not proven yet. So there are whole models people have built the way you're saying that theoretically, if you do the 6 months, then 6 months that, and then 12 months that, you'll actually probably get better results. So the concept is very much there, but there is no data yet. So therefore, I can't. It's not recommended.
FDA approval is there. We have only 24 months or 18 months maximum.
Yeah.
We cannot use it for more.
No, but okay. In the real world, what happens sometimes, I would prescribe it for 18 to 24 months. Okay, but the patient may stop at 1 year, 6 months. So if later on, if you think the patient needs it, you can still give it again. So the total exposure in lifetime should not be more than 24 months. I have gone up to 3 years in some patients, but by and large, 24 months.
Right. Thank you.
Thank you, Dr. Amrish. I think let us go to the second talk, and that is on maximizing outcomes in geriatric spine fractures by Dr. Kamran. Dr. Kamran is Professor Orthopaedics, Apex Trauma Center, AIMS. Dr. Kamran? Special interest is spine surgery, and he does a lot of complex trauma, but close to his heart is spine, so he will be talking on surgery.
Okay, thank you, Dr. Vijay. Can you hear me?
Yes, sir.
Yeah. Thanks, Vijay. So thank you, Dr. Amrish, sir. A lot of overlap is going to be there because a lot of treatment of vertebral compression fractures actually focuses on the medical treatment. I mean, it's only, let's say, a sentinel sign. The VCF is a sentinel sign of existing osteoporosis in a spine fracture. So let's see what we can do as orthopedic surgeons to maximize the outcome, which includes both the drug therapy as well as the surgical strategies. Right. So spine fractures actually constitute almost 50% of osteoporotic fractures. So that's, if a patient has osteoporosis, almost 50% of them will have spine fractures. Fortunately or unfortunately, most of them are asymptomatics, and only a few, who have, they will have pain, but they don't really go to the doctor or come to the hospital for treatment. So a lot of them escape the attention of treating physicians because sometimes they are asymptomatic, but mostly patients ignore them, thinking that, okay, it's just an incidental pain. So they never come to the light of the physician. And the majority would heal with conservative treatment, and only a very small segment of the vertebral fractures, say, let's say, it's quite a big variability there, 15 to 30% have some kind of a adverse sequelae. But what's important to notice is that once a patient has had a vertebral compression fracture, the risk of subsequent vertebral fracture actually increases 5 to 12 times. Some of the papers are citing 10 to 12 times the increase in the risk of vertebral compression fractures. But most of the data is saying that it increases by about 5 times. Although there are some papers which say that almost 12 times the risk of subsequent vertebral fracture will increase after the patient has had the first incidental vertebral compression fractures. So what are the adverse sequelae which will bring most of the patient to the hospital? One is chronic pain, which is not subsiding. If the patient develops some kind of kyphosis that would lead to poor chest functions. So people come with some kind of respiratory difficulty, and again because of kyphosis they can have a decreased appetite. And obviously if the vertebral compression fractures keep happening or it's severe, then patient might land up with a kyphotic deformity and a global sagittal balance, which can lead to impairment of gait or balance because they're constantly exerting themselves to become straight and not bend forward, which will fatigue their muscles. Very rarely, less than 5% of people will have a neurological deficit with a VCF. They are obviously, once they have had a VCF, and there's a problem with subsequent falls and future fragility fractures. So these are some of the adverse sequelae for which a patient can seek hospital attention or surgical intervention. By and large, the standard treatment of VCF would focus on pain control. You have to do concomitant treatment of osteoporosis. Amrish sir has already highlighted the main points in that. We have to focus on exercises, and in some cases, especially refracting incapacitating pain for more than 6 to 8 weeks. If the pain is not subsiding, patient is having incapacitating pain, in those cases we can consider vertebral augmentation. The conservative treatment again focuses on basically pain management, early mobilization and rehabilitation. Important thing is there's a concept that we tend to prescribe prolonged bed rest for these patients, which is to be avoided. So the emphasis here is that you have to avoid prolonged bed rest for such patients, and you try to mobilize them as early as possible and rehabilitate them. The analgesia for such patients, the first line drugs are NSAIDs or PCM. If we cannot control them with NSAIDs and PCM, then there is a role of calcitonin, nasal calcitonin or IV calcitonin for just a short period of 2 to 4 weeks. It has been seen that calcitonin works wonderfully in reducing especially vertebral fracture pain. It's very effective in just vertebral fracture pain. It is not really supposed to be an anti-osteoporosis drug of choice, but it can be given as a pain controller in VCF. IV pamodronate can also be given. It has also shown very good results for control of pain, the analgesic effect, and teriparatide also interestingly has shown analgesic effects apart from obviously its anti-osteoporotic effect. So the surgical indications, especially instrumentation, not just the augmentation in form of vertebroplasty or kyphoplasty, they are basically for unstable fracture. Like any other fracture, you have fracture dislocations in elderly, you have to do, so it itself is by itself an independent indicator for surgery. Patients who have chronic pseudoarthrosis, the Clumel's lesion with instability, they also would require some kind of surgical intervention. Patients who have neurological deficit along with a vertebral fracture, they should be taken up for surgery for decompression of the retropulse fragment as well as stabilization. Patients who have severe kyphotic deformity, either because of pain or because of neurological deficit, they again should be considered for correction of their kyphotic deformity. Now, the challenges which face a spine surgeon in osteoporosis is because the biomechanical strength of fixation is correlates directly linearly with BMD. And these patients have highly porous bone and weak cortices. So there's a challenge in getting the screw purchase, as well as if we are using interbody cages, then because the bones are soft, the vertebral bodies are soft, there's a high chance of subsidence. So we need to understand that the insertion torque, pull-out strength, and fatigue failure are linearly linked to BMD. The weakest link in fixation of osteoporosis in spine is the bone implant interface. So basically, the pedicle screws don't hold in the bone. And the most common mechanism of bone failure would be a screw pull-out or screw cutout. So we need to get that concept in mind. So what are the strategies which we can opt for while treating osteoporotic patients? One is that we can increase the extent of surgery, which means the number of anchors or number of segments that we are going to put pedicle screws can be increased. Let's say for a normal fracture, if you're going to instrument 2 levels, for osteoporotic fractures, we might have to go 1 level higher up and 1 level lower. So we instrument 3 sides up and down. Another concept would be to, rather than just a isolated posterior fixation, we can also do an interbody fixation, do a 360-degree fusion so that there's load sharing in the vertebral body also. So add interbody fusion to a posterior fixation. That would also decrease the load or cutout of the pedicle screws. And we should avoid ending the construct as transition zones like a thoracolumbar junction or a cervical-thoracic junction or lumbosacral junction. Don't end your construct there. We have to go higher up. So how do we increase the construct strength? The most common armamentarium which spine surgeons have is the use of PMMA, the used common polymethyl methyl acrylate cement. So it has been seen that if we cement the screw tract, it increases the pull-out strength of screws by almost 150%. So that's a very good, a technique to increase the strength of screws. So for cementing, we have two kinds of screws. One is the fenestrated cannulated screws, in which you can put the screws first and then inject the cement later. A couple of companies do come up with fenestrated screws. And this is an example of a patient who had a vertebral compression fractures, and we fixed it using fenestrated screws. You can see the screws have been put, and after that, we put the cement, and that increases the hold of the screws in the osteoporotic vertebral bodies. Another option is to first put the cement into the pilot hole and then quickly put the screws. The only problem is sometimes it leads to extravasation and sometimes in the canal. So that's a bit disadvantage. And you have to be quick enough so that the cement is not set before you're putting the screws. Other options are you can aim the screws towards a stronger subchondral bone near the end plates. You can direct the screws medially and connect them with transverse connector. That will also, as a whole construct as a whole, increase the strength of the construct. We can augment the screws with some laminar wires or hooks or bands because the lamina is cortical and it doesn't get affected to the same extent with the osteoporosis. So we can, at the end of the construct, we can either use wires or hooks or bands. And don't tap the screws because it has been shown that under tapping or no tapping can increase the pull-out strength of screws by almost 50%. So what are the changes which can be done to pedicle screws, especially for osteoporosis? One is that people have tried increasing the diameter and length of the screws. They have increased the pitch as well as the threads, just like the osteoporotic, like cancellous bone screws we use. They have deep threads. They have designed conical and tapered design rather than a cylindrical pedicle screws. They are also supposed to increase their strength. The only problem with conical screws is that suppose you have to back out the screw be half ton or 1 ton, then the screw loses quite a bit of strength. So you have to be very perfect with your length, and you cannot unscrew conical screws. V-shaped thread designs have been tried, and a different shape design have been tried, and V-shaped has been found to be very good in increasing the strength of the screws. Another options is to do a HA coating of screws, and this is one of the companies is giving HA coating here. Also, Medtronic provides the HA coated screws, and the problem with HA coating is that once the bone has formed onto the screw, if you have to revise it, then it becomes an issue because a lot of bone is taken out with the screw, and it virtually leaves no option for revision. People have tried cortical bone trajectory also. Cortical screws were introduced in which more of the pars interarticularis portion was used and the screws were aimed laterally. However, biomechanical studies did not support that they are increasing the strength in osteoporotic bones. So they did not come too much into the use. One option is to use bicortical purchase. Normally, pedicle screws will only engage about 80% of the length of the body. But there is an option for bicortical purchase, but obviously you need to be careful about the structures which are entered to the vertebral body. So if you are careful, that is an option. And then expandable pedicle screws have also been introduced, although I have not used them personally. Another option is commonly seen surgical, complication in osteoporosis is junctional failures, especially proximal junctional failures. So people have used PMMA again to stabilize the proximal junction. Some people have done a prophylactic vertebroplasty of the upper instrumented vertebra as well as the one higher above. And they have shown that it does decrease the risk of junctional failure, especially junctional fractures at the upper level. Some people have used tapered or transition rods. They're tapered rods, and what it does is they create a buffer, because if you are going to do a fixation of the osteoporotic spine, the higher unprotected spine is subjected to higher load. So what people have done is they have increased the fixation levels and then used a tapered or transition rod, which is not that stiff. So that might reduce the junctional failures. At the lower junction, what people have done to reduce the amount of lower junctional failures, they have started putting sacroiliac or S2 LR iliac screws. That again increases the strength and avoids the junctional failures at the lumbosacral junction. The bone cement, a bit about it. PMMA is the strongest bone cement which is available. It gives almost immediate stability for your construct. The problem with PMMA is that it does not degrade, and so when osteoporosis keeps on increasing, it becomes like a bag of cement, a permanent foreign body. It does not integrate into the vertebral body, so that is a big problem, especially with the vertebroplasty and kyphoplasty, which use PMMA cement. So later on down the line, it becomes like a foreign body. So that is why they sort of went out into disrepute. People have come up with the options of calcium phosphate cement, which integrates into the bone and degrades, and hydroxyapatite cement. But problem with these two cements is that they don't have the biomechanical strength of PMMA. So it's a sort of a balance that you have to create with calcium phosphate and HA cement. You might have to augment them with instrumentation, posterior pedicle based instrumentation. A word about perioperative Peritide people. What another option to increase the strength is, or to avoid failure, is to use perioperative teriparatide. And some people have actually come up with studies that they used teriparatide immediately post-op, and they showed that it did decrease the incidence of PJK due to bone failure. And they could show, like Dr. Amrish had said, one of the slides, he had shown the transaction of the vertebral body on a PQCT, and it did show that immediate post-op teriparatide increased the volumetric BMD, the fine bone structure, and bone strength. And these are the Japanese paper, and they had showed that if they gave teriparatide starting from the immediate perioperative period till about 6 months, and they could show that they followed it out to 6 months, and they showed that the failure of screws in the osteoporotic bones was quite less. They could actually document it. So the drug treatment, we have already seen that we have to give calcium, about 800 international units of vitamin D. There are basically two groups of drugs that you have to focus on: those which limit bone resorption, and bisphosphonates, alendronate, and Rankel antibody denosumab. And another group is the one which stimulates bone, so which is teriparatide and abaloparatide. The recommended doses, the recommendation is basically give bisphosphonate for 5 to 10 years, give a drug holiday after 5 years with bisphosphonates. Basically, nasal calcitonin is not to be used as a treatment for osteoporosis, although it can be used as an analgesic for 2 to 4 weeks. HRT has gone into disrepute. It's not used for osteoporosis any longer because of the concern with cerebrovascular events as well as new carcinogenesis. So HRT is not used. It was being used some time back, but not any longer. So teriparatide, we are already by and large seen. The only thing I would like to focus on is there was a meta-analysis which shows that if you compare teriparatide and alendronate, teriparatide was more effective at building lumbar spine bone mass. So especially in the spine osteoporosis, teriparatide is actually more effective than alendronate. So that we need to keep in mind. So it has a very good role in VCF. And also, as compared to bisphosphonate, teriparatide was seen to be, led to accelerated healing of VCF. So bisphosphonates, there's one concept which says that bisphosphonates would stop the function of osteoclast, and that would delay in healing of fractures. But especially in osteoporosis, it has been seen that bisphosphonates do not delay the healing of VCF. That is one concept. And the second thing is, as compared to teriparatide, the healing is better when you compare it to bisphosphonates. So on both the fronts, teriparatide is a better drug, especially when we are looking at vertebral compression fractures. So one concept that we need to again look at is that the treatment effect of teriparatide on BMD diminishes rapidly once you stop teriparatide. So after 2 years, when you stop the teriparatide and you don't start any other drug, the positive effect of teriparatide on BMD would diminish very fast. So it's very important that we follow up with some kind of an anti-resorptive treatment. Just abaloparatide has also received US FDA approval, but it's not that commonly available in India. Another interesting study that I came across was that there are two things. One is that you can give initial 2 years of anabolic agent like teriparatide and then follow it up by 5 years of anti-resorptive agent. The other option is that patients have already received bisphosphonate or some kind of anti-resorptive therapy, and then we start some kind of anabolic agent like teriparatide. But what was seen was the effect of teriparatide after a patient has had bisphonate therapy was not that effective as giving teriparatide first and then following it with anti-resorptive agent. So the best course of action is to give anabolic steroid in the first 2 years and then follow it up with some kind of anti-resorptive agent rather than doing it the other way around. Bracing also has its roles. What it does is basically maintain the neutral spine alignment and limit flexion so that patient does not load the spine more into kyphosis. The best kind of orthoses are those which have or known as active orthoses, which encourage the patient to exercise their posterior extensor muscles. So they keep reminding the patient that you need to reduce your forward bending, and they are called active arthroses. They encourage strengthening of the critical extensor muscles. So that's an important concept. We really need to work on the extensors. So exercises, another positive thing that we have to emphasize while treating VCF is exercises, and avoid prolonged bed rest. The exercises should focus on extensor muscle strengthening. We have to focus on postural training, reduce the kyphotic posture and risk of fall. That will also improve the back pain because the patient will not fatigue that much. And there are two programs which are specifically designed, that's called PDPT, or Balanced Proprioceptive Dynamic Posture Training. And there was another program which was initiated by Sinaki, and that is called a SPEED program, the Spinal Proprioception Extensor Exercise Dynamic Program. This is actually a at-home program. So these all had a very positive outcome in the treatment of VCF, and the patients were able to come back at a much faster pace to their pre-injury level. Now coming to the controversial topic of vertebral augmentation, which is vertebroplasty and kyphoplasty, which was in vogue some time back. It's definitely indicated for patients who have incapacitating pain, despite having been tried conservative treatment for almost 6 to 8 weeks. If they are not getting better, it definitely has a role. There were two very landmark RCTs by Calamus and Bookbinder, which came in NEJM in 2009, which showed that there was no significant difference between placebo and index procedure, which led to the American Academy of Orthopaedic Surgeons pulling off these two procedures from the insurance list. They said that they are not recommended. So now both these procedures do have a role, especially in patients who have failed their conservative treatment. So they should be reserved for patients who are not responding to a conservative treatment and having incapacitating pain. With regard to kyphoplasty versus vertebroplasty, there's no superiority data of kyphoplasty, which is definitely much more expensive than vertebroplasty. So if you are going to go in for cement augmentation in VCF, then the treatment of choice should be vertebroplasty rather than kyphoplasty. And kyphoplasty, there are a lot of papers which are saying that, came out and said that kyphoplasty is not cost effective because obviously it's much more expensive than vertebroplasty. So to summarize, most of the vertebral compression fractures can be treated conservatively. But at the same time, as orthopedic surgeons, we must begin anti-osteoporotic treatment. Otherwise, patient is going to come back again with a fracture. Vertebral augmentation procedures with with the classical PMMA cement should be reserved for patients who have failed conservative treatment, and surgery should be well indicated. You should not jump into surgery in these cases. Thanks very much.
Thank you, Kamran, for the excellent presentation. I think we'll have only one or two questions from the
Dr.
panel
Vijay.
because we are
Dr.
getting a bit late now. Yeah.
Dr. Vijay, one
Dr.
question
Vineet,
can I
yes.
ask?
Yes, please,
Dr.
please.
Farooqi, Dr. Kamran Farooqi, thanks now for nice presentation. I just want to know about the latest topic which you have discussed in the last slides. You have said that vertebroplasty or kyphoplasty is reserved for those patients in which the conservative management is not working.
Yeah.
So is that mean that we should go for, we should not attempt for fixation? Or if at all we need to do the fixation, so whether it should be done before the vertebroplasty?
No, they are two different things. Fixation is not indicated for every vertebral compression fracture. If a patient comes to you with VCF, you have to go for conservative treatment. If the patient is not getting better, you should, especially pain, right? Then you should go in for VCF. But if the patient has some other indication like a neurological deficit or a fracture dislocation or a severe kyphosis which needs correction, in those cases, we can go in for fixation with pedicle screws and decompression. And at the same time, to enhance the purchase of screws, you can either use cemented screws or even, vertebroplasty at those levels. Okay.
Means vertebroplasty is not a substitute of the fixation. The fixation has to be reserved only for cases where neurological deficit is there or kyphosis is there.
See, fixation, the role of surgery or instrumented fixation is different from vertebroplasty. Vertebroplasty is basically to relieve pain. The main function of vertebroplasty is to relieve pain, whereas fixation has its own indications. Like, if the patient has deficit, you have to do a decompression. In those cases, you cannot leave the patient with just vertebroplasty. You have to do some kind of fixation. Similarly, if the patient is falling into kyphosis, in those cases, you have to correct kyphosis, and you cannot correct it with just vertebroplasty. They're two different topics altogether.
Okay. Thank you very much.
Thank you.
Should I start, Kamran?
Yes, sure.
Okay, so now coming on from spine to acetabulum, because acetabular fractures in elderly, they represent the most rapidly growing segment of acetabular trauma. And if you look at epidemiology, 2.4 fold increase in the incidence of acetabular fractures. Just let me minimize the videos. Over the past quarter of century, fastest growing subgroup of patients with acetabular fractures. This is the fastest growing subgroup of patients. There are a few studies. So fracture patterns, are they different? Yes, because the hair fracture, we are getting a fracture by fall. More than 60% of the patients, they come with acetabular fractures and they have fall. So there is a unique mechanism of trauma which results in fracture patterns. Fortunately, more uniform than the variety of patterns sustained in high energy trauma injuries in young patients. So fracture patterns are quite common, and they are mainly anterior column injuries, anterior with posterior hemitransverse. It's a classic osteopenic acetabular fracture pattern. You can have any kind of fracture pattern, but since most of the cases, they come with the history of fall and the direct impact on greater trochanter. So this kind of fracture pattern is common. So in one study, there were more than 64% of the cases they had anterior column involvement. So classic fracture characteristics are anterior column displacement. It gets lifted, rotated, quadrilateral plate involvement, medialization of femoral head, and gull sign, like superomedial roof impaction. Whenever the head goes medially, so there is marginal impaction on the superomedial side. So if you look at plain X-ray, this is something like you can see the marginal impaction, you can see medialization of, so this is typical geriatric fracture. And if you look at the scan, this is the kind of scan, quadrilateral plate off and anterior column displaced. So this is a typical fracture. And obviously we'll do routine investigations, all cases, Jude views, all cases, inlet and outlet X-rays, and all cases and CCT of the pelvis to look at the better fracture personality, associated pelvic fractures and articular displacement and type of marginal impaction. Your quadrilateral plate fracture, sometimes it's simple, sometimes it's comminuted, so better fracture personality will be there. So what is the goal? Like goal does not differ from those of their counterparts, and it includes congruent and stable femoral head underneath weight-bearing dome, rapid mobilization, and attempt to return to baseline level of function. But what is the problem in specifically geriatric age group? So these goals, they are complicated by medical comorbidities, a lot of pre-existing joint diseases. These things we have to see, and then severe osteoporosis. So first take home point, I would say early medical optimization and risk stratification should be done. So we have geriatricians with us. So as early as possible, as the patient is fit for surgery, any geriatric care, any medical care should be taken care of, so that patient becomes, if at all patient has to undergo surgery, surgery can be done in time. So treatment options like any other fracture, non-operative, yes, a lot of these patients I will show you the indications when non-operative treatment. Non-operative treatment, earlier period, bed rest and traction, now it has no place in the management. We all know that if a 75-year-old person is put to bed rest and in traction for months together, then what will happen? So there's a very high mortality and morbidity of that. So basically, whenever pain is okay, bed to chair mobilization and non-weight bearing mobilization with the help of walker. And then you get repeat x-rays, and suppose pain is much more than anticipated. So maybe there is pathological movement at the fracture site, or there is displacement in serial x-rays. So if it is not there, then non-operative treatment can continue. And then operative, what we are going to see is open reduction internal fixation. Percutaneous, like personally, if it is displaced, we have to open it and do it. If it is minimally displaced, we always try conservative non-operative treatment. So percutaneous, you are subjecting much more to problems, like if you start putting a lot of percutaneous screws. And then total hip replacement, you want to do it acutely after fixing major column displacements, or because most of these fractures, they are anterior fractures. So acute total hip means you go anterior, you fix anterior portion, then make the patient. So two approaches, a lot of blood, lot of surgical time. So you have to decide, you want to do acute THR or you want to wait for some time, because few of these patients, they will develop secondary osteoarthritis and they will come back with the demand of total hip replacement in the second go. So challenges in the management is acceptable reduction, but better thing in old ages, their demands is not as much as the demands in the younger age group. So even some amount of mal reduction, we know that accept absolute anatomic reduction and functional outcome, they are like, it depends upon the reduction, a good functional outcome. But even some degree of mal reduction, they accept very well, because their functional demands are slightly less than the demands of younger patient. And then the bone quality, we have to assess that, then we have to plan accordingly, looking at the osteoporosis and osteopenia of the patient, and whether patient can tolerate. This is something very important. You have to minimize the time of surgery, you have to minimize the blood loss. And so same kind of surgery is different in an older age group. You want to come out early, so if you are using ilioinguinal approach, you try to do maybe lateral window, just try to put your fixation from one window, or maybe lateral two windows, or isolated stopa. So you want to minimize the blood loss, minimize the anesthesia time. And so like this case, severe osteoporosis, poor fixation. So this patient came to us after this kind of failure. So we have to know that these patients, screw purchase is going to be less. So you have to maybe apply one more plate, or you have to do something extra to keep this in place, because it is again medialized. So now coming on to the first thing, non-operative, I have told. So open reduction internal fixation. So current literature, it supports that primary open reduction internal fixation of most of the fractures, they should be attempted in most elderly patients who are good surgical candidates. So if you look at the father of vestibular surgery, Laterne Jude, 120 patients, more than 60 years, and very good results, good to excellent results. And then the largest series on vestibular fractures in elderly age group is by Carroll et al. At 93 patients. More than 50 years, average age was 67 years, average follow-up, the minimum follow-up was 2 years and maximum was 15 years in this study. And surprisingly, around 70% of the cases, they had lasting reconstruction at the 5 years. So if you choose your patients wisely, then open reduction internal fixation, it is like the indications are same as in the younger age group. So indications are instability, incongruity. This is 60-year-old male and displaced posterior column, posterior wall. So you can do a very good reconstruction of this. Open reduction and internal fixation will give very good result. So coming on to choice, so all fractures, they are approached in a obviously pattern specific manner. If it is anterior injury, you go anterior. If it is posterior injury, you go posterior. So fracture patterns are mainly anterior. So ilioinguinal approach, I don't remember when we conventionally did a ilioinguinal approach. So you use either lateral window or two windows or maybe isolated stopa, and Dr. Viveki is fan of iliofemoral approach in almost all the patients. So you have to choose your operative approach looking at the fracture pattern. Reduction is sequence disimpaction of medial. So you look, you put a shank pin in the femoral head from the lateral side, trochanter side, pull it out, then reduce the anterior column and disimpact the marginal impaction, and then reduce quadrilateral plate. So if two things we say that they have got, they are harbinger of failure, they are marginal impaction and quadrilateral plate, because quadrilateral plate is the one which is stopping the head from going medially. And if there is even slight malreduction of anterior column, there is a higher tendency of head to go medially. So these are the steps. So quadrilateral plate, it is difficult, fragile, and invariably it is comminuted. And that's so in older age groups, it is quite comminuted sometimes. So this patient, obviously it is anterior injury and CT. This is a typical picture, anterior column, and now you look from inside, you will find quadrilateral plate, there's marginal impaction. So most of the patients, anterior column with hemitransverse type. So this is one way of fixing the quadrilateral plates. Spring plate, Dr. Sen is a great fan of applying spring, even Dr. Kong. So this kind of reduction can be achieved. Another case, osteoporotic, you can say head is totally medialized and primarily anterior injury. Again, this is a typical anterior injury. Anterior column is lifted, and you can see from posterior side, it's a hemitransverse component. It's going on the posterior. So this kind of fixation can be done for these patients, putting screws from outside to fixing the posterior column, which has got most of the quadrilateral plate with it. So there are various ways of fixing quadrilateral plate. So this is, now you can look at the osteoporosis in this patient, and if you look at the scan, this kind of picture, again, more or less same fracture pattern, but you can see combination of quadrilateral plate. So we started fixing the quadrilateral plate after doing best possible reduction, but obviously in osteoporosis, this type of fixation does not stay, and then obviously it had to be. This is a sort of combined stopa with ilioinguinal, so you can say it is extended ilioinguinal approach, and good reduction and fixation can be done. We have to understand, especially in elderly age group patients, bad prognostic factors. So in all the patients in more than 55, 60 years patient, you have to look at gull sign. There is a paper where isolated gull sign, they started replacing. Well, almost all the patients, they fared very bad. Wherever there was gull sign, there was marginal impaction on the top. Then look at femoral head impaction, because if there's combination of femoral head impaction, combination of marginal impaction of acetabulum, chances of failure are going to be very high. Hip dislocation, pre-existing osteoarthritis, femoral head and neck fractures, and posterior wall comminution. So instead of putting a graft, it's better to use a femoral head graft and this is one of the indication of doing primary acute total hip replacement in older age group. So total hip arthroplasty, like combined ORF and acute THA, JBJS American study by Mayers and Wallaces, 57 patients, 12 years follow-up, good to excellent outcome in 79% of cases. But most important thing is inclusion criteria. Like another paper from Journal of Arthroplasty, Journal of Orthopaedic Trauma, 16 of 18 patients, they had lesions primarily of posterior acetabulum. So they were looking at femoral head defects, they were looking at marginal impaction of acetabular side, they were looking at combination of, and they were looking at maybe associated fracture of femoral neck. So all these, they become indication of acute THA after stabilizing the column or the wall. So yes, there are indications, but very less in the small subset of fractures. They are managed by acute THR. Like this case, this is my case. Like look at the CT. So we tried to, because patient was 55 years of age, so fixed anteriorly, fixed posterior. This is not a bad fixation. But now if you look at the x-rays, now I'm wise enough that I can look at the posterior wall combination. And so it failed miserably, and then we had to replace. So we looked at the scans later. There was marginal impaction of acetabulum, marginal impaction of femoral head. There were abrasions, and it was shattered posterior wall. So there was no point, doing osteosynthesis for this patient. Minimal anterior fixation, we could go posterior and do acute total hip in such a case. But now I've told you this very small subset of patients who are going to get benefit from initial fixation and acute total hip. But we have to understand these injuries are mainly anterior based injuries. So anterior based injuries, another method is you fix it anteriorly if it is quite displaced, and mobilize the patient. Few of them, they will come back, and you can always do total hip replacement in the second sitting. Like this patient did anterior reconstruction. The major advantage of doing anterior reconstruction here is you will create a very good acetabulum for subsequent total hip replacement. You will make the continuity of acetabulum, and acetabulum will be, conducive for a very good acetabular cup. So replacement can be done. So if the patient is elderly, very poor bone, unlikely to hold a screw combination, questionable medical state, so open reduction is totally out of question in such cases. So a chart, if I can make a algorithm with acetabular fracture in an elderly patient. So quickly, the first thing is quickly evaluate for operative risk. Patient can undergo surgery or not. If patient unacceptable for surgery or not fit enough. सर क्या सुनना चाहते हो आप?
बढ़िया है ये कहाँ से आ गया बीच में?
ये बहुत
शराब बुरी चीज है.
शशांक. Okay, so unacceptable for surgery. Obviously, this is non-op rapid mobilization, toe touch, weight bearing, and suppose patient is not doing well, then you can always go in for single surgery, single incision surgery. But patient is acceptable, like low risk for surgery. And now you have to see patient is non-ambulatory, severe osteopenia, low transverse, like roof arc angle is quite high, posterior wall is less than 20%. Undisplaced fractures, or there are a lot of fractures which have got secondary congruence. Stable fractures, obviously they will go towards non-operative. And if patient is now patient can tolerate surgery. Now this is something very important. If surgery can be done within 3 hours and by a single non-extensile approach, then open reduction internal fixation is a good choice. But if it is irreducible through simple single non-extensile exposure, protected time, surgery time expected, severe combination, displaced femoral neck fracture, femoral head fracture. So there are indications of doing acute THA, but they are very less, I must tell you. So open reduction and internal fixation to make the continuity of the column with primary THA, or you can fix the anterior portion and mobilize patient, and after some time you can do a second total hip. So fracture patterns are different, and because the mechanism of injury is different, still if there's a big posterior wall chunk with dislocation, we have to fix it, even if the patient is quite old. So if there is intra-articular piece after reduction, we have to fix it. So there are indications of open reduction internal fixation. But most important is understand poor prognostic factors for ORIF, especially in this age group. Few subset of patients, they will benefit from fixation and acute total hip arthroplasty. Early mobilization is the key, and like other fragility fractures already discussed, evaluate and treat osteoporosis in these patients. Thank you.
Thanks, Vijay. Very nice lecture. But Vijay, I mean, I don't do much of these fractures, but most of the literature which I have read, which is coming out now, is saying that in geriatric patients, it's better to do a total hip than go in for fixation. What is your take on that?
No, I told you. I think there are indications of everything. There are indications of non-operative. There are indications. Suppose a 55, what is geriatric? Like 60 years of person with isolated posterior wall fracture. So I think you would like to fix it, or maybe anterior injury. It is. I have shown you so many cases. So how you are going to replace if there is a total disruption of anterior structure? So it's better to fix the anterior structures and call, because then it will be two surgery in the same sitting. So you are fixing anterior, or else now there are newer implants which you can you can fix even in pelvic discontinuity basically. So if you are using those implants, doing that extensive surgery, then yes, there are papers. I know there are papers doing early arthroplasty also in this age group. But what we do, what we do, I think this is absolutely clear. Posterior impactions, dome impactions, femoral head defects, femoral head abrasions, shattered posterior wall. So it's better to do fixation and replacement in the same sitting. Otherwise, most of these injuries are anterior injuries. So fix it and then wait. And if every third patient will come back with the pain, you can always replace that. But in the meantime, you have maintained the congruity of the SWM.
Thank you.
Dr. Vijay, can I add something?
Yes, sir. Please, please.
Yeah. No, there are some very interesting things about SWM fractures in health.
Sir, welcome, sir. Welcome.
Yeah, thank you. Thank you. I had little problem in logging in first because I was logging with the previous password and all that. Anyway,
Right.
So coming to the point of conservative management, there is something that in elderly patients, even a small part of incongruity is more acceptable as compared to a younger population, because the outcome has not been found to alter with the smaller incongruity in that kind of an area. So that's one fact. Second is that because osteoporosis, as the topic today is is a very important factor in this elderly group. Some patients are really osteoporotic. I had been looking at these factors for quite some. Last year, I think I must have treated about 25 of these cases of elderly SWM fractures. So in some of them, the bone quality is very good. And in that cases, the comminution is less and they're reconstructible. So probably this bone quality and the kind of a comminution, if we take it for an analysis, does give us a very good idea about it, whether we have to go for a reconstruction or we have to go for a replacement as such. So that, and if we are going to a replacement, I personally feel, because as you said rightly, that it's an anterior injury. So I personally go with the iliofemoral approach, stabilize it and come down with the same Smith-Peterson and do a THR. That's one way. And in some of the cases, I did go with the two ways, that initially I had some percutaneous fixation and then went with the standard posterior approach, which I usually do. So, and in these cases, definitely we are happier because we have done both the things with less invasive surgery. When they talk about reconstruction, in elderly, they say that if you are doing a surgery, do with the minimally invasive approach. So they primarily recommend AIP or Estopa's approach, whatever you may say, for the stabilization of the anterior column, which primarily is injured in this area. And for replacement, they advise that these are the patients who are likely to get dislocations. So preferably is to use a dual mobility hips in this kind of a situation. And that way, so minimally invasive approach is for AIP them, and hips have to be dual mobility hip. And definitely, because the bone qualities in that kind of a combination is likely to be affected, and you have to use that head to fill up wherever you find a defect into that kind of an area. So it is a very interesting thing, as you have rightly pointed out in all those factors, that this is different than when we take care of the adult patients with SWM fractures. Quite okay.
Thank you, sir. Thank you, sir. I think next talk is by Dr. Vivek Trikha, and he will be talking about very important fracture, which is distal femur fracture in elderly. Dr. Vivek को I think introduce करने की जरूरत नहीं. Everyone knows him very well. He's professor orthopedics, Thames Trauma Center, and obviously major interest in pelvic acetabular trauma and all complex periarticular fractures. Over to Dr. Vivek, sir.
Okay, thank you. I hope I'm audible and visible. I'll be speaking on distal femur fractures in the elderly. The learning objectives of this talk are going to be to learn about the fracture personality of distal femur fractures. Are they different in the elderly? To analyze the evidence and outcomes regarding the options which are available to us right now, and also to know something about the options which are in vogue right now but may become the future gold standards. How common is the distal femur fracture, especially in geriatrics? The first thing which we want to know, and which it is not that common as the proximal hip fractures, which is 10 times less the distal femur fractures are as per the hip intertrochanteric fractures are concerned. But what we want to know is that after 60 years of age, there is a dramatic increase in the distal femur fractures, especially in the female population, just like the intertrochanteric fractures. if you see this graph, the red line is for the females and the blue line is for the males. And this is a paper from America where they have studied over 15 to 20 years the distal femur fractures from 84 to 2007. Same thing, if we would like to see what is the survival of the patients in Kaplan-Meier survival curves, we find that they have got better survival than the hip fractures. So that's the good point about the distal femur fractures, that like intertrochanteric or other fractures, they are not that bad to say. However, if we look at the prosthetic, periprosthetic fractures and we look at the non-periprosthetic distal femur fractures, here we find that the periprosthetic distal femur fractures who already have a total knee replacement done have got a worse survival than the non-periprosthetic distal femur fractures. So this is something which we should be knowing, that if we are dealing with a periprosthetic fracture of the distal femur, they might have a less chance of survival as compared to the non-periprosthetic. What are the problems which can cause these mortalities or the lower survivalship? The relationship we see is most of these patients, as all geriatric patients, are in ASA 3 or 4. The comorbidities are very high, and the loss of hemoglobin is the most common complication which is present in such patients. So we should be taking care of these things when we are dealing with a distal femur fracture, especially in geriatric population. Let's look at what is the injury pattern in distal femur in the geriatrics. Is it different from the young population who usually have C3 fractures, comminuted intra-articular distal femur fractures? You look at this graph and again you will find that most commonly the fractures are 33A1, which are the spiral distal femur fractures, non-intra-articular, which form the main population or the distribution of these fractures. If you look at this paper, which was again of around 800 patients of distal femur, the most common is again 40% is A1, extra-articular distal fractures, especially the spiral ones. And the second most common is the periprosthetic one. So when you are dealing with these fractures, remember that most of them might be having a very thin line or are extra-articular or maybe periprosthetic. So this might be the commonest fracture which you will see in the distal femur, especially in the geriatric, the A1 spiral sort of a fracture. What do we have for the implant choice? We have looked at the injury patterns, the epidemiologies. Now let's come to the management options. The implant choice for these are, first, the nails. The most common nails which we use for such fractures will be the retrograde nails. Can we use the normal retrograde nails? No. The retrograde nails needs some specific characteristics in the form that it should have multiplanar locking bolts. You cannot have two medial to lateral screws going in the distal femur nail, which are going to form your treatment pattern. Else, besides the multiplanar screws as you see here, you can have lock bolts which are inside with threads inside the nail, where these bolts go back and thread themselves, giving much more stability and preventing the toggling effect. So these are the newer implants which are required when you are doing the distal femur nails, especially in geriatric. You can see this nail, it has got the bolts, the multiplanarity, as well as has got threaded screws in the threaded portion inside the nail, which prevents the toggling. So if you are using a nail, better use these sort of nails with multiple screws, bolts, multiplanar, threaded. A fracture like this, just to see whether it's an intra-articular fracture line, and that's what you do. You fix these fractures with a retrograde nail, ensuring that you have got multiplanar screws which are threaded inside the nail. Another fracture which has got a thin fracture going inside the articular fracture line, and the same thing, a retrograde nail can easily fix such fractures, and it can have union later on in normal results. Beware of one thing, never use a short nail. because if you use such nails, there is a very high chance that you can have, these are straight nails, you can have a periprosthetic fracture, which will lead to further morbidity for such patients. Another thing which you can have with a nail which you are using is known as the bell clapper effect, especially in geriatric population. What happens is that if you are using a nail, the diameter out here is very broad. Your nail can maximum be 12 or 11. So what happens, like the bell in a temple, it goes from one side to the other on the nail, and the bone is moving from one side to the other. This causes the rotation and will lead to failure. So what you need to use sometimes in such fractures in osteoporotic patients with very thin cortices are long segment blocking screws, which can be used. We normally use them in distal fragment, but in such cases in osteoporosis, you might need them to be used in the proximal fragment also. And this is a paper by Hassan Mead from Tampa, Florida, which shows that the long segment blocking screws have increased the stability of the retrograde nails, especially in the geriatric population, where you are putting in the blocking screws, multiple blocking screws in the proximal fragment as well, to make sure that the stability is enhanced. The second option which you have is the pre-contoured locking plates, which we have been using quite often for all the other distal femur fractures, which you can use on a single side, another A1, or you can say going inside the intra-articular part, and the same sort of a fracture can be fixed besides a retrograde nail also with a distal femur locking plate. Periprosthetic fractures, which is the second most common part, can also, if your prosthesis allows you, you can have the retrograde nails. Else, you can also be using the plates, long plates, which can go right up to the lesser trochanter to avoid the further progression of these fractures on the proximal side. So locking plates can be a viable option for these geriatric fractures where you have the distal femur. Which is more stable? A biomechanical study which was done in 2011 showed us that if you take that single nail with 2 locking screws, spiral blade, multiple planarity screws, and the distal femur locking plates, you will find that the best ones were torsional stability. The rotational stability was best provided by the plating of the locking plates, whereas the axial stability or the axial strength was best provided by these multiplanar screws, retrograde femoral nail. This is another paper just published in 2019, especially for the biomechanical in elderly population, which also says the same thing, that retrograde nails are superior in the axial deformations to the compared to the locking plates. That are the 2 most common things or the options which we are using for geriatric fractures. The thing is, do these geriatric distal femur fractures have a higher rate of complications, which we have to be taken into account while we are treating them? Yes, this is the paper from Pittsburgh, which showed that there is a non-union rate of nearly 25%, and also surgical site infection rate is pretty high, especially in these elderly population when they have these femur fractures of the distal femur. What are the complications which we can anticipate? You have a distal in a 78-year-old male fracture. He was having a supracondylar, intracondylar sort of a fracture pattern. And this is how that fixation was done somewhere. You can see that most of the screw, the plate is smaller, a lag screw, multiple thin screws, cortical screws have been used with one locking screw out here. In spite of all this, the plate tries to the bone tries to have attempt to union. You can see the callus getting formed, but you cannot have these patients non-weight bearing for long. And what happens is that in spite of falling, this plate becomes loose with all these fractures. You can see that the cortical screws have gone. There's a new bone formation, hypertrophic non-union happens, and the plate breaks, because you cannot expect these elderly patients to be non-weight bearing for so long. So what we did here, and when this patient came to us with this fracture out here, the only thing which I did was use a longer plate, locking screws which are equidistant, multiple fixations with no bone grafting out here. And later on, you can see that just giving it the stability which it required, we were able to get good fixation as well as the union in such case. This is another complication which is very common in elderly patients, especially if you use, you can see this fracture, intra-articular C3 sort of a fracture in an elderly professor who was there from a University of Agriculture. And this is how that fixation was done. Relatively okay fixation, equidistant screws, locking screws, everything was there. But within a few weeks, this is what happened. The collapse happened, the screws of the distal femur gave way, and you could see that there was a varus problem. So how do you avoid such complications? You can use a dual plating options, and the indications for them are when you have poor bone quality, comminuted fractures, and very low periprosthetic fractures that you have. The newer things which are coming up is another case of 63-year-old lady with distal femur, which was fixed relatively well with a plate. But this is what happened later. You can see that equidistant screws were there, a lot of working length was there, but still patients are walking on it. And if there is some gap, it will lead to be a load bearing device, which can lead to failures. And this is how it failed. So the next option which you can do, if you are using a longer plate, you have to go way high, but will it be sufficing because the patient has to bear weight onto this? So the next thing which is coming up is a nail plate construct where you can use an intramedullary nail and also use a side-by-side plate fixation, which may be providing you the stability, the torsional as well as the axial stability, which is required for such cases. Is there any evidence? Yes. In recently, 2019, Liporaci has given this that it might be a good technique for native and periprosthetic distal femur fractures. This is a paper which has just been published in JOT in 2000 February and is also going to be published in a big way in August, I think, in the issue of August, where they have found that the dual plate, and they have done a biomechanical study on both dual plates and plate nail constructs, and have found that both of them give relatively good stability, but in vitro, in where they are using it and the bone models, dual plate provided a better fixation. However, they say that fracture morphology, surgical approach, healing mode, and the implant cost should be considered while taking care of which of the ones which you want, dual plate or a plate nail construct, which is the newer option which we do not use for younger patients. But in distal femur in geriatrics, you need to think of these newer options as well. Is there any role of primary arthroplasty in the distal femur? And I'll just say that just like in intertrochanteric fractures, we have 20% non-union rate in elderly. Distal femur replacement, like we are doing trochanteric fractures replacements, can be done in a geriatric population with very low fractures with combination. This is one of the first papers which came in 2016 by Madhav Karunakar. And recently, there have been 2 systematic reviews, especially in 2019, which said that there is of 181 patients, which concluded that there is a definitive role of acute total knee replacement in distal femur fractures in elderly population with severe combinations. You can give and achieve faster mobilization and discharge of elderly patients. This is a paper which was published in 2019 in Injury, and that's, you will find that this was an Injury where they have said a systematic review again, where they find that it is the best way in certain amount of elderly geriatric patients, where the comparison with other fixation is the only thing which will give us longer term outcomes. This is a fracture with osteoarthritis, and they have done a replacement megaprosthesis for such. So I'll conclude by saying that distal femur fractures are not so uncommon as we used to think in elderly age groups nowadays. The nailing is having an option, which should be multiplanar locking bolt mechanisms, especially for the AF-type fractures. The lock plates give us the torsional stability, which is so much essential in these osteoporotic bone cortices. Dual plating, both medial and lateral, as well as plate nail constructs, These are the newer things which are coming with recent literatures in the last 2 to 3 years, 4 years, and will be an important tool in the geriatric population. Primary arthroplasty can also be considered for the severe type C fractures, which we sometimes will be encountering in these geriatric fractures. And as always, we do not need to forget to treat osteoporosis. Thank you very much for your hearing.
Thank you, Dr. Vivek, for this excellent presentation. I think over to the panel for questions. I'm getting a message questions later. We are again short of time, I think.
Dr.
So I think we, yes.
Good evening. Dr. Bageja this side, Dr. Vijay.
Dr. Bageja, yes, Dr. Bageja.
Congratulations, very good talk. I just want to know that this nail is available here in India, this disc of human nail with multiple screw fixation.
Yes, if you use the MNC companies, there are 2 or 3 out of them, which is the common one, which is available at the retrograde nail. They have these options of multiplanarity and having the threaded screws both proximally and distally as well.
Which nail, which company?
I'll tell you later.
All right. Okay, thank you.
Okay, Pradeep, I think let us from distal femur to proximal tibia. Dr. Jitendra Maheshwari, sir, Director of Orthopaedics Max, formerly at Ames, additional professor and author of, you can see the book there. We also read this, and over 40 years of experience in orthopedics. Over to Dr. Maheshwari, sir.
So we are going down slowly, and I will talk about proximal tibial fractures in elderly. In last 3 months, there have been, to my knowledge, at least 6 webinars on proximal tibial fractures, and I have attended each one of them, and I've learned so much in last 3 months thanks to Dr. Shyam and company. But this was a topic which was probably not discussed in any of these webinars. That's what I realized. So it was a very good exercise for me to focus my thought on this topic of proximal tibial fractures, particularly in elderly. Treatment of proximal tibial fracture continues to evolve. I think every webinar told me something new, something different. It was very fascinating to attend these webinars. Newer classifications, we know, from Schatzker to column concept, newer approaches. We used to have only 1 or 2 approaches. Now they're posterior medial, posterolateral, and a new concept of 3 degree stabilization of the proximal tibia. And this is so much important, mainly operative treatment in young people. Now, where are we as far as elderly people are concerned? In the elderly, there are additional challenges of treating these fractures. One, they have osteoporosis, so more combination, poor hold of implants, and higher fixation rate. So expected when you treat a patient with osteoporosis. In addition, they have osteoarthritis. Already painful and stiff joint they have. They already have weak muscle. They have because not so much mobile and already deformed. So they are, hanging with a very thin thread, moving around, mobility somehow, and then this fracture happens, and it is a turning point in their activity and mobility actually. Very, very serious deterioration of quality of life because of this fracture and these fractures. In addition, they have comorbidities. They have neurological comorbidities, Parkinson, neuropathy, and also diabetes, CV, everything. Almost every elderly patient has these kind of problems. Psychologically, very fragile at that age. So if you ask them to sit down at home and they're used to walking, going for a morning walk, that's a big deterrent to them. Early mobilization is very important. It can more or less change their life from 100 to 0 if they cannot move around because they lose their independence. That's why a very calculated approach to these fractures are very important in elderly. Now, even elderly are changing these days. They're more active. A 80-year-old, 20 years back was like gone case. Now we have more active 80-year-old and they want to remain active and they live very independent life. So, the whole society is changing and so are the elderly changing. So that's why we should need to look at these elderly people with upper tibial fractures as a different class altogether compared to all the other webinars we've had, which are more focused on young adults. So let's look at the conventional treatment. Conservative traction, we have been doing since ages. plaster treatment in very, very minimally displaced, perfectly all right, and then operative. The aim is to get them in acceptable position. Use of bone grafts or substitutes may be required to get them a reasonable kind of a position. We are not too much finical about getting everything minute detail wise perfect, because their demands are different, their expectations are different. So we have to fine tune the treatment for elderly. Now the challenges in conservative treatments are general, in-bed immobility, time taken, prolonged rehabilitation required in conservative, and arthritis does progress. If you immobilize them for 3-4 months, they're not moving around, they become much worse. The goal of conservative treatment in this patient is actually acceptable malunion. We just want them to remain up and about. We know they're not going to go out, walk 5 kilometers every day, but they should be able to move around and do their normal activity and not lose their independence. That's why acceptable malunion is good enough in large majority of these cases. Operative cases have their own challenges. Their skin is fragile. Multiple incisions often required for this surgery may be counterproductive, can lead to healing problems. Fractures are difficult to fix for obvious reason. Fragile bones, complex fracture pattern, they're mostly comminuted. There's a crushing of bone and actually bone loss. And there's a need for graft which has its own morbidity. So there are problems with operative treatment. Mobilization is guarded. You have to ask them to walk with crutches, blah, blah, blah. Very difficult for an elderly person. Time to healing average is almost 4 months and maybe sometimes 6 months. Complications can happen and that can be a disaster for an elderly person who is waiting to walk, and after a few months fixation failure happens or infection happens. So operative treatment, though ideal for an adult person, also is quite tricky for an elderly person. You cannot expect them to use these things which are required. How long? And then if you keep them conservative, don't move them, this is what they start developing. So problems of rehabilitation is also very important in elderly people. After fixation, suppose you have done and it fails, replacement is a big challenge because there's a higher rate of infection. It's a very superficial joint. Implant removal itself becomes an issue, and exposure, etc., becomes a big issue. So if they are grounded because of failure, because of arthritis having progressed, replacement of the knee is not an easy bit. So what is the best treatment for an elderly to get him back pre-injury status as soon as possible? That's what we want an elderly to do, whether it is a trochanteric fracture, whether it is any other fracture, they should be up and about within the permission of their health status. That's the ideal goal for a elderly person treatment. Now, how is it possible to have one operation which gives an elderly what he deserves? Painless, stable, mobile hip, mobile knee, and in the quickest possible time. That is, the wish list of an elderly if he has a fracture. And that can only come from something like primary. But there are issues even there. Now, but we can see the trend in other joints. In trochanteric fracture, comminuted in elderly people, we are moving away from fixation to replacement as a primary surgery. In shoulder, all upper shoulder fractures comminuted, there is a great movement towards replacing them and not fixing them because complications are too much. The same is the trend in elbow arthroplasty. So what is the problem with doing a primary knee replacement in elderly? Because that's what he wants. One operation, we should work, make him up and about as quick as possible. So looking at the trend on other side of the body, probably doing a primary knee replacement is a very considerable option. One must consider it. Now, reason for this trend, activity and demands of a 70 plus. On the left and the right is not the same 70 plus. The demands are different. So you have consideration for the person on the left has to be different than person on the right. Then most importantly, we have now available technology which can take care of whatever is deficient in the human body and compensate it by something artificial like sleeves, like augmentation cone, etc. So the surgery has evolved in favor of making it more predictable by way of replacing, where you take away the nature's role of creating all kind of complications that we have seen even in distal femoral fracture. But there are challenges in replacement. It's a bigger undertaking. Skill requirements are great. Affordability is a big issue in our society. Special implants are required. And if complications happen, it's a disaster. So it's a very calculated decision to do replacement in certain quality and patient under certain conditions. This was a publication from September 2019, where joint replacement as a primary treatment in proximal tibial fracture in the elderly, and it was concluded that it's a very potential good option in selected patients. So it is not something that we should just shy away from doing just because it sounds big. Now, how to choose the right patient? Let me give you this last message. Conservative in low activity patients with good family support. Now, they don't have to be in the hospital. They can be treated at home on a Bola-Brown splint very easily in our society where there is a family support. Affordability is poor, and that forms almost 70% chunk of our Indian society. They can be treated conservatively in a very, very comfortable way. No complications happen because family takes care. Operative treatment in active patients who have good quality bones, luckily, and it is a fixable fracture. You can do it with reasonable fixation methods, and patient can tolerate a reasonable period of rehabilitation. You can consider operative treatment in such patients, but replacement in active patient where the bone quality is very poor, it is almost non-fixable, and patient cannot tolerate prolonged rehabilitation, not very walking, etc., etc. And of course, he can afford, and the surgeon can afford to do it. So all these three things are important. That's how we can choose between conservative, operative, and replacement as an option. Just to give you an example, multiple crust tibia like this, what can you fix it here? Whatever you may do, this patient is going to limp, maybe become from a walker to non-walker. I think using current technology of joint replacement is good. If patient can afford, he's fit, and surgeon can do it. That's a very quick fix solution to this problem. Another one, this lady was booked for bilateral, 55-year-old though, but she was booked for bilateral uni-compartment replacement, but she fell down, and on one side, she had a middle compartment arthritis already, developed lateral crushing of the lateral condyle. So I decided there's no point doing anything here. So I did a replacement on the right and uni on the other side, which was quite good for uni. And she did very well. Now, irony of the fact is this. There are trauma surgeons who can fix everything. They don't even look at the knee. They just look at the fracture. Then there are replacement surgeons who are willing to replace almost everything. And they think, no, we don't want to waste our time. But they are in between humble knee surgeons who can do both, and they choose what is best for the patient. I think that should be our approach. To conclude, in selected cases, primary knee replacement is a very valid option where you are fixing, you have to be sure about the bone quality, should augment fixation whatever way possible, use graft, bone substitute, whatever, and go slow with rehab. And conservative treatment is a very much acceptable treatment because patient demands are low, and you can do it because more often affordability and skill is also an issue. Thank you for your attention. Hello.
Thank you, sir. Thank you, sir, for such an informative talk. I think only one question we can have from the panel. Otherwise, we can have questions at the end of session. I think. Thank you, Dr. Maheshwari, sir.
Dr. Vijay,
I think
Dr. Vijay, we don't have questions from audience at present. So I think
okay.
Finish off the presentation and then take questions. By the time I get anything, I'll let you know.
So now from proximal tibia to ankle, now I invite Dr. Balwinder Rana, who is Associate Director Orthopedics at Max Hospitals. Dr. Balwinder Rana, please.
Thank you. After enlightening talks from very great faculty about other parts, we come to ankles. So I thank DOA, Dr. Sharad, Dr. Hitesh, Dr. Harmesh to have given me the opportunity. So let's start by looking at this patient. We are getting some kind of a disturbance from.
Dr. Rana, आपका voice quality बहुत echo आ रहा है.
Okay, is it better now?
Yeah, it's a bit better. There was a lot of echo. Are you using headphones? आप headphones या तो use कर लीजिए. Because there was a lot of echo.
Generally, I get a very good quality with my laptop. Without the headphones is a bigger problem. There could be an issue of connectivity. So
maybe. It's better now.
नहीं, अभी ठीक आ रहा है. It's okay now.
Okay. So is it okay? Should I continue now?
Yes, please.
So let's look at this fracture. It's a 65-year-old lady with a trimalleolar fracture pattern, which I treated about 15 years ago. She had a minor fall at home with a minor twist, and she sustained this fracture, which we can see is a small medial malleolar fragment, a comminuted fracture at the level of the syndesmosis of the fibula, and a small posterior malleolus fragment there. So this is how we fix it, but at about 2 weeks of surgery, it was already kind of drifting apart. So there seemed to be a lateral subluxation of the talus, and the joint was not aligned. And at about 3 weeks down the line, we could see that the fixation is failing. The syndesmosis is wide, and the medial space is much more than it should be. So we took it up for some kind of a revision, removed the middle 2 screws from the plate, removed the medial hardware, and put 2 fully threaded 3.5 cancellous screws through the syndesmosis, reducing the talus back into place. Now, this is a fracture which kind of learned a lot of things from this. This is 6 months post-op. This did heal, but obviously with some amount of shortening of the fibula, which makes the patient prone for arthritis later on. So what are the realizations from that kind of an injury? So we have a pronation abduction pattern, which leads to a comminuted fibula at the level of the syndesmosis or slightly above it in an osteoporotic skeleton. So these patients who are elderly are more prone to have this kind of an injury pattern, which is because of a fall of abduction. Their control is not great. The younger patients have more of rotation injuries or high sporting injuries where they have pronation external rotations. But this injury pattern of pronation abduction is more common in the elderly because they've lost the control and balancing power sometimes, and that's the way they fall. So there's this pure abduction movement at the talus, which creates a comminuted fracture of the lateral malleolus, and the posterior malleolus is kind of chipped away. It's not a syndesmotic ligamentous injury. There is a small posterior malleolus fragment with a medial injury, in the end being a deltoid avulsion or a small medial malleolus fracture. So classical pattern of an elderly osteoporotic skeletal in the ankle. Now, in this kind of scenario, we fixed the lateral pillar only and the medial pillar. We forgot about the through and through syndesmotic instability. Even though we would have fixed, suppose we would have fixed the posterior malleolus in this patient, the syndesmosis would still have been unstable, for the simple reason that there was a lot of comminution in the area of the fibula at the level of the syndesmosis and above it, which would have made the syndesmosis still unstable even if we had fixed the posterior malleolus. So this is one of the indications where you want to be more aggressive in fixing the posterior malleolus as well as putting in the syndesmotic screws. So in the elderly, we need to elicit, and we find that there is a minor injury leading to a major fracture patterns with more comminutions of the fibular area, of the medial side also, and more subluxations of the joint. We must elicit the history of past fractures, and obviously in elderly, the comorbidity history have to be elicited accurately, including the diabetes, peripheral vascular diseases, neuropathies, nephropathies, cardiac issues, and everything. Apart from the usual examination that we do in the ankle fractures in the young patients, we must assess circulatory and the neurologic status in most of these patients clinically by palpating pulses and by neurologic clinical examination on the opposite leg. But if you find that we are in doubt, then we should not hesitate in going for a documentation by investigations for circulation and neurology, because it's extremely important that an elderly patient does not have a neuropathic foot. If he has an ankle fracture, it could be a catastrophe with usual techniques are followed. Diabetes mellitus has to be ruled out. We have to do an HbA1c, and it is recommended in some of the studies that every patient who's above 65, if is not documented to have osteoporosis and has an ankle fracture, should have a DEXA scan to see if the bone marrow, if the density of the BMD is below -2.5 and qualifies as an osteoporotic fracture. Usual X-rays are needed as in the young population, but a CT is required more often in all of the elderly fractures, and more usually if there is a subluxation or dislocations, we must do it after provisional reduction. That's about the clinical part, the type of fractures that we see in the elderly and what are the issues. If we come to the treatment options, conservative treatment has a role in non-displaced closed fractures, which are obviously stable fracture patterns. So which are the fractures which will fall into this category? Like an isolated fibular fracture, which is stable, which is not displaced much. And there is no middle column or the medial column. There is no syndesmotic injury and there is no significant medial injury. Then we can treat this patient with conservative treatment with a cast or a boot. The other indication would be an isolated medial malleolus fracture without concomitant syndesmotic or a lateral injury. Now, in these two scenarios, whether there is an isolated fibular fracture or a medial malleolus fracture, we have to rule out the middle column and the opposite column injury by doing stress testing if at all there is any doubt about the injury to these columns. And there are three ways of doing it. Which one of them is best in elderly is slightly different. We can do that by standing stress X-rays, gravity stress X-ray, or a manual stress X-ray of the ankle. In the younger population, we see that the standing stress X-rays are generally relied upon. So you can, sometimes you in a Weber B fracture, which is undisplaced or slightly displaced, you apply a cast and you can ask the patient to walk and do an X-ray at about a week down the line and see if it is displaced. But that generally does not apply. So we have to have more stability in osteoporotic skeletons. So we see that in younger patients, a manual stress or a gravity stress will subluxate an ankle which is stable on standing. Now, we still rely on standing in the younger patients, but on standing stress X-rays, we cannot rely in the elderly population. So we have to do a proper stress X-ray if we doubt about integrity of the syndesmosis of the medial column. Now, all displaced fractures, all other fracture patterns, unstable fracture patterns, which means a two-column injury, that means the ring is broken at two places, medial or lateral, then we need surgery, and surgery gives better results. Now, if we are considering surgery, then we have in the elderly, we have three scenarios. One is there is no osteoporosis. The BMD is documented as normal earlier, but we don't do it usually. Then we treat it as a usual fracture in a younger patient. The patient could have osteoporosis without comorbidities, that is the BMD is below 2.5 or it looks like it's an osteoporotic fracture. And then there is a third category where there is a patient with osteoporosis and with a lot of comorbidities. Specifically, we need to consider diabetic mellitus. Coming to the uncomplicated osteoporosis, which we call as there is an osteoporosis, but there are no comorbidities, or even though if there is a diabetes mellitus, it is rigidly controlled and HbA1c is below 7 is considered as an uncomplicated osteoporotic fracture. There are no other comorbidities, no neuropathy, no peripheral vascular disease. The BMI is 25 and less, and there are no medicines which are causing osteoporosis. So all of these will come under the category of an uncomplicated or a simple osteoporosis. And in these patients, the problems of holding the implants in the bone can be counteracted by modifying your surgical techniques a bit. So what we do here is that angle stable locking plates, which we now have for the distal fibula, even the variable angle anatomically contoured distal fibular plates are independent. The screw fixation is independent of the BMD, and that is what we need to use in these patients who have documented osteoporosis. A combination of cortex and locking screws can be used because the cortical screws will fail by breaking their larger diameter. But if you have all the locking screws only, then the implant fails catastrophically. If it has to fail, then the entire plate can come out, just get loose from the bone. So a combination of cortex and locking screws is better. We need to have more tendency towards more posterior fibular plating, more tendency to fix posterior malleolus, and with the posterior malleolus, as we discussed in the case that we saw, syndesmotic screws may still need to be used. There are a few reports, and I have no experience with intramedullary interlocking nails for the fibula, but these are the things that we have to be considering when we are considering fixation of osteoporotic ankle fracture. Posterior plating, one by one, we'll take this up, just a slide on each of them, one of them. More role in osteoporosis because biomechanically it is stable. We can get, if you apply a plate on the posterior surface of the fibula or posterolaterally, we can get bicortical purchase in the distal fragment. We can avoid the joint penetration by the distal screws. And if there is a short fibular fracture, we can actually create oblique fibular fracture we can create an interfragmentary screw compression through the plate. And obviously in these patients, the skin cover also is a problem. And then a better soft tissue cover is provided by a posteriorly placed plate. So here's an example of a 61-year-old male, again a trimalleolar fracture, posterior malleolus, lateral malleolus, and a medial malleolus, a quite unstable injury. We fixed it by a posterior plating of the 1/3 tubular plate on the posterior malleolus, and then a posterior plate on the fibula. So although we could have opted for a lateral plate, but here the fracture is pretty low. So a lateral plate here would have given us unicortical couple of screws here only, and maybe one or two interfragmentary screw. So instead of that, we opted for a posterior plate, which gave us bicortical screw purchase in the distal fragment. Now, posterior fragment also needs to be fixed more often, and we have to be more liberal in our approach in fixing the posterior malleolus with a plate. Here is a previous hip fracture, 72-year-old female, had a bad skin on the medial side, not looking that great. So we had to temporize, did a CT scan. You see the posterior malleolus there. External fixator applied, the joint was reduced, waited for the skin to become okay, and then we did a posterior plating as well as a lateral locking plate for this patient. Another example, BMD of -3 documented on anti-osteoporotic treatment, 58-year-old lady. This kind of injury, posterior malleolus, and then a long oblique spiral fracture, supinatial external rotation type of an injury. You can think about considering a lateral plate here, but again, think about if you put a plate on the posterior side, you can get at least 2 or 3 interfragmentary screws, and then a bicortical purchase here again if the plate is posterior. So that is what we did, posterior malleolus plating again, and a posterior plate on the fibula. Now, bony avulsions, considering the syndesmosis fixation, in osteoporotic skeleton, when the patient has an ankle fracture, syndesmotic injuries, ligamentous are uncommon, and these are more commonly bony avulsions. And these are small bony avulsions. So if they are fixable, we should be going on the back and fixing it even if they are small. Sometimes we have to put posterior fixation and then as well as syndesmotic fixation if there is a combination at the level of the syndesmosis. We discussed that in the first case. And in severe osteoporosis, the debate between how many cortex and how many screws does not apply. It has to be 2 screws, 4 cortex. And sometimes I have had occasions to use 4.5 cortical screws to get good purchase in an osteoporotic bone in the ankle in the syndesmotic areas. Now here is an example, a 60-year-old female, steroids on asthma, pronation abduction injury, again, a small chip fracture of the posterior malleolus, possibly not amenable to fixation, a syndesmotic injury, community fracture of the fibula and the medial injury. I'm going to skip the video for shortage of time. So we use 2 screws in the syndesmosis. In a younger patient, I would have opted for 1 3.5 cortical screw, but here 2 screws, 3.5, and all 4 cortex have been purchased. So if sometimes in a diabetic patient, we have to substitute these screws also and go all the way to the tibia, which are called fibula pro tibia screws. And it is justified to obtain better purchase from the fibula to the tibia with more screws. Now, if we add a couple of K wires on top of a plate in a lateral malleolus fracture, which are a wire which are having bicortical purchase, that has been documented to show to increase the stability of fixation strength to 80 to 200%. There is some evidence in the literature. I have no experience with an interlocking fibular nail. And for cement augmentation, there are no specific studies for the ankle. In Charcot's established on neuropathy, uncontrolled complicated diabetics with osteoporosis, an ankle fusion is definitely an option. And an ankle fusion or a TTC hindfoot nailing in a patient which has a almost bedridden daily life, only activities of daily living, is again an option for primary fusion. This is a patient we did recently, diabetic mellitus, presented to us 8 weeks post-injury, treated conservatively. He was subluxating laterally. As soon as he was putting weight, the ankle was dislocating laterally. That is his CT scan. You see already the Charcot's process has started. This is not salvageable. Even at 8 weeks, this joint is gone. So we did a transfibular ankle fusion for this patient. There are other measures which have been discussed. We need to treat them. I'm not going to go into these. So we need to do drug treatment for osteoporosis. Finally, the results of ankle fracture in the elderly. There have been ample studies in literature which claim that without surgery, the results are poor. And with surgery, if there are no comorbidities, then above 60 and below 60 in the elderly, there is no difference in the outcome. But if there are comorbidities, like diabetes, then there are problems and we need to follow certain protocols. So the take home is injury patterns are a bit different. Abduction, pronation injury is more common. Minor injuries can lead to severe fractures. We always have better outcomes with ORI. We should not be nihilistic about surgery in the elderly. Locking plates have to be used on the lateral side, and a combination of sometimes on the lateral side locking plate with an intramedullary KYS does give more rigidity. Posteriorly, from the fibula, posterior plating is to be considered more often. Protibial screws from the fibula, that is transsyndesmotic screws, maybe 2, 3, 4, if as indicated, may have to be used. And in cases of established neuropathy, complicated diabetes, and Charcot's, fusion is an option, and long non-weight bearing is required post-operatively. So thank you very much.
Thank you, Dr. Balwinder, for such wonderful presentation. I think we can have one question quickly, and otherwise we'll have all the question at the end of presentation.
Can I ask?
Yes, Harmesh, please carry on.
Dr. Balwinder, you said you will prefer a posterior plate compared to a lateral plate on a fibula.
Yes, sir.
Right, but at the same time, you also said we would like to fix syndesmosis most of the times. So if we put a posterior plate, how are we going to fix the syndesmosis?
So you can, if you are fixing the syndesmosis, then you can put lateral screws independent of the plate, which is possible to do with a washer if necessary. Or you can put the plate on the posterolateral border of the tibia, not exactly posterior, and you can still get bicortical purchase into the distal fragment, and through the plate you can get anteriorly into the tibia because the fibula is a bit posterior, so you can get bicortical syndesmotic purchase through posterolaterally placed plate on the fibula, or you can do an independent of the plate fixation out of the plate.
Thank you, Dr. Balwinder. I think now I invite, Dr. Kong. It must be very late in Singapore, I understand. Dr. Kong, are you there?
Yes.
So Dr. Kong is consultant orthopedics at Farrer Park Hospital and Mount Elizabeth. AO international and regional faculty for so many years, Zimmer faculty for so many years, and for us, he is a star faculty for our all courses at AIMS. So over to Dr. Kong.
Thank you, Vijay, and also thank you to the DOA for inviting me. Can you hear me?
Yes, sir. Yes, sir. You're audible.
All right. Now, my topic is atypical femoral fractures and what we should know about them. You can see on my slide, there are two very similar fractures. One is called typical osteoporotic subtrochanteric fracture, maybe a reverse A3. And the other one is a atypical femoral fracture. So we should get into the mind that we forget about one of them. Okay. There's a new pattern which was recognized about the end of 1990s and near the 2000 because it was around 4 to 5 years after the introduction of bisphosphonates as a treatment of osteoporosis. The pattern was very classic. It was in the femoral subtrochanteric region, transverse fracture, thick lateral cortices. So these were not the osteoporotic patients. And when they did fracture, there was a medial spike. There were low energy forces and they caused by tripping or turning or just no real fall. So they basically broke before they fell as opposed to a fall before fracture. And usually the person is not too elderly, but in the 50s and 60s. They have a very active lifestyle. And sometimes the BMD was normal, if not osteopenic. Some of them had prodromal thigh pains for 2 to 4 weeks, and many were actually on long-term anti-resorptive therapy. And they were prescribed as prophylaxis against osteoporosis. So it went beyond the calcium and vitamin D. And the first few cases we actually saw were related to doctors who had samples, free samples, and they gave them to their mothers and their elderly sisters and other relatives. Some of them had oncologic history with propensity for bone mets like breast cancer, and they were given protection against metastasis with bisphosphonates. And many of them were between about 3 to 5 years duration on anti-resorptives, and particularly bisphosphonates. In realizing how this occurs, one must look at the forces and also the strength of the bone. We keep thinking of mineralization, but there's a condition of brittleness. And if you have an optimal bone strength or brittleness and mineralization, if you have a hypomineralized, you get osteomalacia, so the bone is more bendable. But if you have a hypermineralized, such as osteoporosis and other hypermineralized conditions, you will get a very stiff bone that breaks at very little displacement. So they were akin to stress fractures. And then you look at mineralization and toughness. If you have a normal person with normal stiffness, and you will get this young modulus. And but the toughness varies with the mineralization. So over mineralized bone are actually less tough, although they are stiffer. So when we look at bone strength, what is it that really matters? We keep looking at BMDs, but actually it's the combination of bone quality, which is a factor of architecture, turnover rate, which is remodeling, damage accumulation, which are microfractures, and the degree of mineralization, which is the heterogeneity between the proteins and the mineral matrix. And finally, this combination must be ability to absorb force and stress. But in our clinical assessment of patients, we're only looking at the DEXA scores and also at the QCT for the area and volumetric BMD. So we are largely ignoring the first part of the equation. If you look at this video, it shows you remodeling happening in trabecular bone between the osteoclast activity taking away bone and osteoblast that comes. We are well familiar with this process. What does bisphosphonate do? Well, it concentrates under the clear zone. I think you had a lecture in the first speaker. It binds to trigger sites and exposes calcium phosphate crystals. And bisphosphonates inhibit formation of cytoskeleton. So basically, as the first speaker said, it kills the osteoclast. And without the osteoblast has no trigger to form bone. So essentially, over a period of time, it causes dead bone to occur. It does not inhibit osteoblasts and has a long life, half-life. These are bisphosphonates binding to bone and osteoclasts. It is very useful in the clinical disease of Paget's disease with hypermetabolism, hypercalcemia for metastasis, and some were used in the active giant cell tumors. In these cases that are very brittle, you actually have a high incidence of microcracks in the lamellar bone, and this is the process of stress fracture formation. The Lemma article was in 2005 by Ordina, and they had 9 patients, and they did a histomorphometric analysis. So they labeled tetracycline bone, and they took bone samples, and they found that there was absence of double tetracycline labeling, meaning that osteoblasts did not lay new bone. And because of this, she confirmed it's over suppression or severe suppression of bone turnover. My first case was actually preceded the article by 1 year. This patient was 68 years old, mother of a general practitioner, 12 years menopausal, and was given samples of alendronate for 5 to 6 years. And her T-score was in the osteopenic range when she first saw us. Very active grandmother, brings her kids to school. Presented one day before with left thigh pain of a few weeks duration to a hospital. X-rays taken on this day showed perhaps possible some avascular necrosis in the hip, and she had an X-ray done to prepare her for possible hip replacement. She got up from a dining table one night later, and she developed bilateral femoral midshaft fractures. And on a review of her X-rays taken the day before, we noticed actually there was some line and a bump over here, which is indicates a stress sign. And if you look carefully, I'm not sure if you can see it on your screen, but you can see a black line, which we now call the dreaded black line. And the fractures occur exactly through those parts. And here we did a bilateral iron nailing, and in 6 months you can actually see good callus formation, and she was pretty quick on her feet. What are the radiographic features of atypical femoral fractures? They're usually in the femur, and that's why the name is there. We haven't actually found other features in other long bones. In the subtrochanteric area is the most common, and this is almost typical like this Paget's disease, and they occur with a classical pattern. Some do occur in the midshaft, and rarely do you see some typical fracture in the distal third junction. The cortices are thick. They may have excessive curvature. A transverse fracture is the pattern with a spike like this. So you have a transverse fracture essentially, and then a spike usually on the medial side, and the thickened cortices suggestive of a stress reaction of a subperiosteal reaction. And this lateral cortical reaction, so all these are clinical features, plus the black line that I showed earlier. All this has come down into a case definition by the American Society for Bone Mineral Research. You need to have 4 or 5 out of the major criteria, which is a fracture between the lesser trochanter and the supracondylar flare of the femur. There's little or no trauma, a transverse or mostly transverse fracture, non-comminuted or very little comminution, complete fractures with a medial spike, and incomplete fractures have a lateral cortical break, and a localized periostal reaction. So if you have 4 or 5, this will fall under the category of AFF. No minor criteria are required, but these are clinical features that you should look out for. The cortex appears to be thick, quite unlike osteoporotic bones. There's a delay, there may be delay healing after fixation. Some have prodromal symptoms of varying duration, which is typical of thigh groin pain, often mistaken for hip conditions. Bilateral symmetrical fractures with symptoms are also typical of these atypical fractures. Our claim to frame is actually in the dreaded back line, which we reported in 2010. And we studied 1,500 subtrochanteric fractures in the elderly geriatric population, of which there were only 33 with this atypical femoral fracture pattern. So about 2% or 2.5%. Out of these 33, 32 were on bisphosphonate for over 3 years. 12 of the, or 1/3 of the, they have a contralateral cortical callus on the opposite femur. And all of them had thigh pain about a month or so or more before the fracture occurred. And all the femurs with the black line seen before, that is on the opposite side, completed the break within 4 to 6 months. And only 1 in 12 with no black line fractured in the same period of time. What is the surgical management? The implant choices is important. In the subtrochanteric area, usually an angle stable plate or capillomedullary nail. You can argue whether it should be a long nail or short nail, depending on the curvature of the femur. The midshaft of the femur, usually a nail or a plate. And in some cases, do look at the intramedullary diameter of this, because of the thick cortices, the canal is very narrow. Yes, and this patient was on levandronate for breast cancer management. And we managed to find an adolescent nail that is 8.2 millimeter to fit this, because this was a prophylactic nailing. Primary bone graft is not proven to facilitate healing unless there's a gap or there's a malreduction with the potential for delayed healing. Sometimes in the fixation, you can see the lateral cortex is not well reduced, and this patient went on to break the static locking screws, which shows mobile non-union at the proximal fracture site. So beware of malreduction with a gap. So things like this, if you happen to see this at the time of surgery, you may consider bone grafting or some additional procedure to avoid delayed healing. The femoral radius of curvature is very important when you do the nailing, whether you're using a capillomedullary nail or a standard nailing, because you have to accommodate the curve of the femur. And you should overrim the nail or undersize the nail to avoid tapping fractures, because these are brittle bones you're dealing with, and they look very thick, but they can be very brittle and shattered. Additionally, you should think of considering the prophylactic internal fixation for the other side. So the side that fractured had a fracture, and then the other side has one. So take a look at them before, otherwise you will end up with bilateral femur fractures. You may want to use Perioperative or BMT in delayed union post-ORIF. The question is how to avoid or identify these. What are the causes? The causes of delayed union of non-union post-ORIF. It means the fracture gap was left, and usually this is on the lateral cortex with the nail, femur, it was in varus. Varus or rotational malreduction should be avoided, and preferably using an oversized nail is a mistake, because even though you try to dynamize these nails, they have a static locking effect. So undersize the nails, preferably to allow dynamization to occur should you have a little bit of over distraction. And finally, consider thermal necrosis, because these patients' bones are very hard, and if you're trying to get a bigger nail in, you may cause thermal necrosis, and that may actually be separate from the fact that they are bisphosphonates. What are the take-home messages? Firstly, that they are rare, 2 to 3% of subfrontal fractures in the geriatric population. But if a person comes with thigh pains and has been taking anti-resorptives, do a quite good examination of the thigh rather than opposed to the hip joint. And if you look at the DEXA scores, they may actually be osteopenic rather than osteoporotic. Good radiographs down the shaft of the femur, and always take radiographs on the other side and look for these black lines. If uncertain, a bone scan will usually pick up the first AFF and possibly the other side as well. And be careful when you're doing nailing. Medullary canal size and thick cortices may lead to problems intraoperatively with excessive blood loss and overheating on the remaining process. And finally, fracture should be reduced. I prefer plates for these, and preferably compressed as if you are dealing with a stress fracture or a delayed healing. And you should use all anti-resorptives, but there is some controversy regarding the use of teriparatide or parahormone or BMT, and you should reserve these for patients who have a fracture gap. So we hope that you will know more about them, and it's not just the pattern of the original fracture, but also the other side that shows that little bump that could lead to a bilateral fracture. Thank you very much for your attention.
Thank you, Dr. Kong. It's always a pleasure to attend your lecture. Any question, quick question? Harmesh, you want to ask?
Yeah, you said that sometimes we can plate them.
Yes.
Hello. Yeah. So, is there any special tips if we have to plate these? Do we use double plates, or is it okay to use as usual a plating of femur?
Oh, I would do this. Look at the original femur. Many femurs, especially I believe in India, are in varus. So when you do a nail, you should avoid them. And when you do a plate, you should also try to avoid varus. This lateral cortex here is actually very prominent, and sometimes it your plates or your angle stable devices may actually sit off the bone and promote the varus. So make sure you have well contoured plates, and there is no actual need to add supplementary bone graft in my hands. Most of them heal well, but I always make sure that there is compression at the fracture site. So my favorite here is usually a condyle blade plate, angle stable blade plate, and in some cases, variable angle reverse distal femur plates. Nailing is a challenge, and sometimes you may have to do an extension of your incision a little bit below to push this cortex in, because you tend to enter a little bit over to the wrong side of the trochanter in nailing, because these are very small, short segments. In the shaft, lower part, standard nails will do. You don't need the teflomedullary nail. And because they are more curved, and also they are longer, and also you can have double screws in the neck. So anything in the clear subtrochanteric area, teflomedullary nail or angle stable plate, and lower down, that's a standard anti-grade nail.
Thank you.
Can
Dr. Kong.
I ask a question, Dr. Kong?
Yes, Dr. Sharad.
Invariably, you say that the history of bisphosphonate is there for 3 to 5 years. So do you think it should be mandatory that in all the cases we should take a drug holiday after 3 to 5 years? But with bisphosphonate, though our endocrinologists felt that can be given up to 10 years. What's your opinion on that?
Yes, I think this is in the realm of the endocrinologist. In my personal patients, I have moved a little bit towards the denosumab. I have actually had AFFs of denosumab patients as well. But again, they are in the longer region of about 5 to 7 years, because it's just new. So not many patients are on it yet. And a lot more are on bisphosphonates. But I tell patients personally, I use the cutoff point of 5 years. And then I put them on a drug holiday, which is denosumab, just to change the process, because they both work slightly differently. And especially when these patients are on BMDs or T-scores of up to 2.5 to 3. If they're over 3.5, I tend to use teriparatide. When they in the post-op, especially in the post-op period.
Dr. Sharad, can I just come in for a minute?
Please.
Yeah, actually, this concept of drug holiday, this came because of subtrochanteric fractures only, especially in spine. When they were given bisphosphonates, they started getting these atypical femoral fractures. So this concept of drug holiday came because of these fractures. They said that because osteoclast, they are inactivated, hence they were getting these, and there was no remodeling of the callus. So that's what was happening, they thought. So they said that let's take a drug holiday, and that's how this concept of drug holiday came, because of these fractures.
Right.
I think the question of drug holiday may be more than just post-fracture, but probably a person who is under surveillance either by endocrinologist or by yourself. They should know their BMDs, and if the BMD is either too low, much lower than you expect after a period of bisphosphonates, I think a bone-forming anabolic type of teriparatide is more indicated. Because you're just flogging a horse that doesn't respond, and then adding the risks of ONJ as well as AFF.
Just quick question, like you said, bone graft, like the quality of bone is that good that you can use it as a graft, or you prefer BMPs, like if you have to graft them?
I rarely graft. The bone is the same bone. It's the same bisphosphonate-laden bone that you get from the Hcoated. So I don't feel that the bone grafting is necessary unless you have a gap. Say after post-op and you see that you've mal-reduced and the patient is an old patient, you don't want to do any revisions. You may add some bone graft at the end of your, just before you finish the surgery. The Hcoated is quite close. The other thing is if you have a BMP, 7, for example, you can inject something inside. Some people have reported good results, but we really don't know. But I think the best thing that surgeons can do is to make sure you get accurate reduction. Treat it like a potential non-union and compress the vector.
Right. Thank you, Dr. Kong, for this enlightening presentation. So now we come on to the last talk of the day, and I invite and welcome the teacher of teachers, Dr. Ramesh Sen. He's former professor, PGI Chandigarh, over 600 faculty lectures and over 200 publications. President of APAS, and I think if I start reading his CV, then it will be, I think, one lecture in itself. So over to Dr. Sen, sir, please. Thank you.
So, very good evening, formally, and considering that it is the last talk, so probably I don't think we will have many people to listen about it. But anyway, looking at the topic of periprosthetic femur fracture, we know, I mean, there are the general things we know then, because the arthroplasties are increasing, obviously the effect of trauma subsequently in these is likely to increase, and more so because the aging population is aging more and more. This is likely to result in more cases. It can be after TKR, after THR, but TKR is already taken care of. So I'm talking about mostly about the hips. Now, very important is that most of these happen after the fall, some after the routine fall, and some after the major trauma. But they say that it could be detected beforehand also, and the pre-fracture X-rays actually show the loosening in that area. In reasonable, that was the finding. But how to diagnose? There is a very recent paper which has come up that if you take a software supported CT scans where you can really titrate well with the images, you might be able to see the loosening in very many cases which you may not be able to appreciate in the conventional X-rays. We know that the standard classification, I don't have to talk more about the standards which are already established with the Vancouver system. But there is a very interesting thing is that in Vancouver B2 fracture, meaning by we are looking at a fracture where the stem has loosened out. There are 4 different patterns which have been described. There is a burst pattern, there is a spiral fracture pattern. In these 2 types, they happen to after cemented implants. While clamshell fracture, which basically means the displacement fracture of the lesser trochanter, and the reverse clamshell, which is towards the greater trochanter. Both these happen, as you can see down there in this, both of these clamshell, and they're primarily an outcome of uncemented, while burst and spiral are the outcome of a cemented hips. These happen in case of a uncemented hip. That is something. And then now a newer classification has come up, which looks as a mnemonic to be A, B, C, D, E, F, whether it is apophyseal, it's a bed of the implant, just like our Vancouver B type of fracture, and Vancouver C, just like a clear of the implant. But what they have added is DEF, meaning by dividing one bone which supports 2 joints, just like THR and TKR, you have a fracture in between. Now, this was not described in Vancouver as such. And then there is another way, is each of the 2 bones supporting 1 joint, just around the knee, femur is involved and the tibia is involved. Now, we tend to see all these varieties now. And third is when you have a fracture with an implant, when there is a articulating surface is broken rather than the implant site is broken. So these are the newer things. And another factor is that these very fracture patterns, these very classifications are for all the joints across. It's not only for the hip, this is for the knee, this is for the elbow, this is for all the joints. And this classification system is further referred by the same authors in a different articles also, that they found that this is a better classification. Rather, it carries more information now in the current perspective of these replacements, these periprosthetic fractures. Now, we also understand that we tend to get many of these intraoperatively and some of them postoperatively. Now, there is a very good paper around it, which says that what are the risk factors for that intraoperative fracture. And they found it out female patient, significant femoral deformity, osteopenia, and cortical, where the previous osteotomies have been done. And during the surgery also, if you look at the surgical profile, it's the revision surgery. And as we just saw, the cementless component, when you're trying to put them in the elderly, they're more likely to end up in a intraoperative, the kind of stress the uncemented stem will give is likely to produce it. And a straight long stem and definitely a vigorous manipulation to get the reduction of the hip these are the most important things we tend to see it over there. Another interesting thing, they have found it that there was a specific design which came from the Zimmer at one time, the Proxilog design, which right now incidentally have been discontinued. This design had a very specific thing. There were two transition points from the smooth distal femur to the metaphyseal area, and from that area to the proximal area, the 2 times, and these were imposing a lot of stress, and this was creating that particular kind of a fracture in this thing. So this was this as a stem is important. And when they were looking at the bipolar fractures, now there is a very this thing that they found that when they look at all the risk factors, these are from the 481 bipolar hemiarthroplasties, the main factor which was significant was the door canal type C, which was an important factor. There were other factors like female sex to Viper, junior surgeon, or called duty surgery, and all those. They were there, but they never reached the level of a significance. But door canal type C reached that level. Then this is a review kind of a situation in which they looked at 596 article 34. They found good for the analysis, and they found, as it was earlier also observed, that cementless femoral implant are a significant factor. And as we also know it, that single and double wedge fill and fill implant give 3-fold increase in the periprostatic fractures. We all know about the osteoporotic bone. And within cemented, if you're looking at the cemented side of it, it is the axator stem. They are with more PPF rather than the composite beam stems in this kind of a situation. When we look at the epidemiology in revision areas, what are the factors? In revisions areas, again, uncemented stems are 3 times more often involved in periprostatic fracture, and many are non-displaced diaphyseal fracture because the fractures happen with the lesser energy. The bone is, it's a revision kind of a surgery. They may not be displaced, and you may settle down with a kind of a circlage kind of a fixation. And in this kind of a situation, if you look at the various, this is primarily for revisions only, that most of these cases, you may not even know the trauma also. For the gluteal, these greater trochanteric avulsion injuries, you may never know the trauma, just like it is no known trauma in 53% of the cases, or there could be a simple fall. Mostly they are transverse as far as the avulsion kind of an injury is concerned, and they can be treated conservatively. For B1 kind of a fracture, mostly they will happen from fall from a height, but definitely other causes stay. And typically they are either oblique or they are spiral. And indefinitely we know that it's B1 type of a fracture will need surgery in most of the cases. And B2 and B3 type of fractures, fall from standing height remains the most important thing, and no known injury in another kind of a situations. And then this is again a very standard kind of a algorithm given how to proceed with these things. As far as the greater tuberosity is concerned or a lesser tuberosity is concerned, in greater tuberosity, if it is substantial displacement, we tend to go for a fixation. In lesser, if it is making the joint implant loose, then that is the reason which needs it. And for type B also, if it is a stable stem we are looking for, people have tried many things, wiring, plates, online. And I remember the time when we were doing these cases also, there were many things available. They are talked about in the literature about Menon plates and all those things. But these descriptions, we found it out, they were having anchorage in the proximal till the metaphyseal area. And we found that this is an inadequate fixation. At that stage, we started going up to the greater trochanter. That was in 2000 when we were dealing with these fractures. And in this kind of a situation, we started going at that. These are the LCDCPs during 2000 year, in that era, that we were using, I started using them proximally, more proximally, so that we should be able to reach to the greater trochanter in these kind of situations. And these are the cases which we have done in 1999 or 2000 or something, and that we published subsequently 2007, our some series at that stage, that we must reach in B1 fractures to the greater trochanter in this kind of area. And now all these things have become standards now, the classical, these things have the one. And it is also that whenever we are revising them, we may have to use a long stem also inside if we feel the bone quality is very, very poor. And though in B1 fractures, you do not have to replace it. It is the transverse kind of a fracture pattern where probably even replacement has been recommended in this kind of a situation. But the more things which were talked about recently are the directions. Just like we had a locking plates coming up, but in this, say, rather than the locking plate, you will have to direct your screws around the stem and reaching towards the opposite side cortex. But if you are putting allograft, they must be able to take care of the allograft also in these situations. And as far as this thing is concerned, the people have started double plates also. And if they are down here, they will go for a replacement. This is important. For these are the cable plate osteosynthesis have also been recommended for transverse fractures or cases which have got a severe osteoporosis. And we know that locking plate has been very, very standard in this kind of a situation, and we pose the technique which is very often used for these cases. We have to use allograft wherever we have got this thing. And in this kind of a situation now, with the availability of these hooked plate specifically designed for these fractures, we can have a reasonable amount of minimal stability across this area. With our hook plates, we are able to reach to the greater trochanter also, and we are able to give a reasonable amount of a outcome in these cases when we are stabilizing these fractures. There could be some interesting, as Dr. Kong was just telling about a fracture appearing in this area, which are the kind of a fracture which are likely to subsequently manifest in this way. And this kind of a fixation again in this kind of a bone can give us a stability across this fractures area. Now, if we are looking at B2 fractures where the implant has become loose, this is the situation where we will have primarily to go for replacement. That is the standard teaching, and the standard protocol is going for ETO, extraction of the implant, resurgeon of a longer implant in this kind of a situation. If you do, and we are able to get a reasonable outcome in the subsequent follow-up period. The problem comes in B3 fractures, meaning by the quality of the bone is poor. And again, you can see the same kind of a small fracture line coming up in between these two implant, a THR, which is also getting loosened, and a distal femoral fixation, as Dr. Trekha showed beautifully, the kind of a fracture pattern osteoporosis. And here we have got a combination of it. The fracture getting a stress in that area between the proximal and the distal implant, eventually manifesting this kind of a series. And incidentally, the fixation which has been done has not taken care of graft in that area. The fixation leaves a gap, as Dr. Kong was talking about, the fracture gap in that area. So there is the gap which is left over, and this gap did not allow the healing to happen across the fracture. And incidentally, the stem had been coming out of the cortex at the distal part also. So in this kind of a situation, what it led to was a fracture at that part, and definitely a kind of a bone loss, which you can see proximally also. And now, because it is a significant bone loss proximally, distally, so right now the need was to fill up all that area with allograft. So here, this is what we have been able to do: pack up this area with the graft, put a lot of graft around, holding it with the mesh, so that we were able to have the patient ambulatory after some during the follow-up period as such. So that was about this thing. Now, what happens when the fixation in this kind of a fracture fails? And this is in failure cases, it is advisable that we should be going for a revision arthroplasty. Fixation failure cannot be redone with the repeat fixation. They feel we should expect good result from prosthetic stem because they want to subside. They will be good healing and there will be good outcome. So if the fixation have failed, they usually go for. Now we know that in overall, as far as the this replacement is concerned, this is a standard treatment which has been accepted in many of these B2 and B3 kind of a fracture, and especially and we also know that people have this given a lot about using the allograft in the proximal area wherever the maximum osteolysis is around in these B3 kind of a fractures. There is a specific article in 2014 which talked about that we should be using modular fluted tapered stem in this kind of a situation, which are likely to give a more reliable kind of a result. And this is the perception most of the series published at that time. And then definitely people tend to put up their techniques. Also here, they have published a technique that when you are making an incision with the ETO, you tend to go to the capsule with that very incision so that you do not have to open it much. And this tip can help in getting a better outcome in this kind of a situation. Then these people have used this circlage wire with the circlage wiring and screw, and with a kind of they have noticed they could get it. The another thing which noticed was that when the bone loss significant and we are not likely able to do with the allograft, we don't have allograft, and the kind of situation is bad, in that kind of a scenario, we can use the tumor prosthesis also, the limb preservation system they can be used for the restoration of the limb length and all that purpose. And now we look at these fractures, the systematic review of these periprosthetic fractures, that they were treated. That's a very interesting thing which is there. If you look at the this thing which I have made it up, that we know that B2 and B3 fracture, the standard has been the replacement. Now look at this chart, revision with and without ORIF revision. But this very group, they started taking without revision also. Now this is something, it is published in 2007. We thought little unusual because we are tuned to doing a replacement in this kind of a situation. But this paper said there can be, but they said it subsequently that they were associated with the higher rate of reoperation. So meaning by people were doing simple fixation even in B2 and B3, but the results were not very good. But subsequently in 2019, last year, another paper appeared, which has given same kind of a conclusion that if you look in this, their algorithm in B, if the stem is loose, look at the bone stock again. If the bone stock is, you're definitely, because it is a loose implant, you're revising, but there could be an option that you can still go for reduction fixation with LCP, because they found it out that with previous our data stress, the ORIF using LCP is a valid treatment even in Vancouver type B2 fractures also. That is something which we were not initially thinking. And now this is another paper. It is a kind of a review. They looked at 14 original research papers on this kind of a situation, 5 studies. And then again, they had the same kind of a conclusion that ORIF may be a viable option if bone stock is adequate around uncemented or a tapered polished cell with an intact cement mantle, and the fracture geometry allows stable and automatic reconstruction in B2, and even he says in B3 periprosthetic fracture. That is something different what we are listening right now. But if it is type C fractures, we are sure that these are the fracture which have not much of the controversy, standard kind of a fixations are likely to go in for. And again, another case where the standard kind of a fixations are likely to give us an adequate outcome, this kind of a situation. The difference which has come up is, I don't know how many people are using these cortical locking constructs or the kind of a far cortical lock kind of a screws, but they have been found to be another thing. This is again an interesting observation. People have used list plates. They have also now used polyaxial plate, which can allow them the freedom to put the angle of the screw. But they have not found any significant difference in the two system in this kind of a situation. This plate also, another paper also did not find a difference in locked plating versus non-PPF fracture. There's a very interesting thing that whether you are looking at periprosthetic fracture or a simple femoral fracture, lock plating does not differentiate. The outcome is practically similar in a periprosthetic fracture also, as is likely to happen in a simple non-periprosthetic fracture also. So once you are doing a lock plating, the outcome is likely to be same in this kind of a situation. There is a 2006 which says about that with this kind of a fixation, you may be able to give them unrestricted weight bearing also, though we are always careful about it, but it is their paper which they have advocated. Now, then they have to talk about perioperative situation. Now we are talking about a patient who is likely to be elderly, and these are the patients who are likely to have complications also, including cardiac events and deaths also. The one was the mechanical part of it, another is the general part of it. And in this kind of a system, you might have mortality ratios also quite high. But if you look and compare with the hip fractures, the general hip fracture and periprosthetic hip fracture, very interestingly, the patient with periprosthetic proximal femoral fractures are with lower mortality rate. I remember this first talk which was there, that we have got a 20% to 30% of the mortality after the standard hip fracture. But in periprosthetic fracture, for reasons that they may be more ambulatory or whatever the reasons may be, that they have got a lesser mortality in this kind of a situation. So when you look at the outcome of these cases, these are smaller series, and obviously they have the same kind of a conclusion that in a selected cases you have to do a revision surgery, and in other cases you have to go for this thing. So again, another issue which has been talked about in these cases about the medical management. One of the report was from Kim, as was talked about in the earlier paper also, of using teriparatide. But these people, this Antonio et al. Group, they studied the teriparatide or strontium, and they found there is no comparative study, so we cannot say how conclusive they were, but they say they had very satisfying clinical results by use of teriparatide or strontium in this kind of a situation. So when we look at the outcome of periprosthetic fracture, the preferable, that is the same kind, that it's preferable to perform internal fixation with plate, with hooks, and in doubt the revision surgery is the issue. Now, what are the failures? Now we have been able to manage periprosthetic fracture, but they are likely to fail. What are the basic failures? If you look at the conventional plate versus locking plate, there has not been much difference in them. Only difference is initially we used to do mostly conventional plating. If you look at the graph, now more and more people are likely to use a locked plating, but it has not altered much. As far as the prosthesis is concerned, wherever we are doing a revision surgery, we do have hip dislocation, we have infection, and we have a loosening as the complication which are likely to come in this periprosthetic fracture in this kind of a situations. And so coming over to the 2019 perception of these cases, going for a kind of a conclusion, the choice of locking or conventional plate for the treatment of type B1 and cemented or cementless nerve component fixation for B2 and B3 fracture had no significant influence on the risk of reoperation. So they have eventually agreed to whatever has been there earlier also. And as we know it out right now, that we are advancing little in the kind of a classification, we are doing little more. Overall, we know that B2 fractures, if they are not associated with loosening, we are likely to go for a fixation. But the new thing which we have seen coming up in the literature is that we can go for fixation of B2 and B3 also, if the implant stability can be restored in a good quality bone. Otherwise, replacement has been a standard management in B2 and B3, as well as all the failures coming up in B1 also, or wherever other the failures are coming. But as was in this guest editor said, that definitely it requires a little of experience to manage these problems, and they can definitely be very challenging at many of the time, and decision making is very vital. Thank you.
Thank you, Dr. Sen sir, for this excellent talk. Always so much new to learn from your lectures. I think we can have one quick question from the panel.
I don't think there is anybody now.
So there are more than 2,500 live children. No questions from, okay, Dr. Kong. Yeah.
Can I have one question to Ramesh?
Yeah, please.
Great talk. I find a very difficult fracture to fix is the greater trochanter fracture, where people have tried to wire them down and they will get high riding trochanter. Do you have any tricks for GT fractures, although they are not classified highly, but they are nasty in my experience?
The problem is that whenever if you feel that these fractures are not likely to do well with the reconstructions, the replacement has definitely become more acceptable option in all those kind of a situation where the failures are likely with the standard management. Because if going through the literature, that's what they all say, that rather than failing in fixation in the first go, it's better you have it change in the disease and go for a replacement as an option, because that age group, we cannot keep on experimenting with likely failures. So a lot will depend upon the kind of a bone over there. The amount of a combination is a very good indicator of the quality of the bone we may be encountering. So if we are likely to end up with the failures with the fixation, or it's a difficult fixation, I feel that age we may be better going with the replacement in this kind of a situation.
Thank you, Dr. Sen. I think this was the last talk, and on behalf of Dr. Malhotra and DOA, I would like to thank all the faculty and panelists for their valuable time. And over to Dr. Hitesh Lal, Dr. Manish.
And sir, we can have questions for Dr. Sen's presentation. Any discussion or question?
Dr. Kamran, I think you have unmuted yourself. You want to ask something?
No, not a question, but I just wanted to thank you for organizing such a, academically interesting and thought-provoking MIDCON. Thanks, Dr. Hitesh, and thanks, Team DOA.
Can I ask one question?
Yes, sure, sir.
Yes, Dr. Ramesh, please.
Yeah, Dr. Ramesh, if there's a cemented hip and a stemmed total knee below in the same side, and the patient has an interprosthetic fracture with not much of a bare bone.
Okay, Harmesh, I think I will answer you. Dr. Manish, we have 2 or 3 minutes.
Yes, sir. No,
we have
you can take 10 minutes.
Very good case from Harmesh. Harmesh, I think that case is worth discussion, I think, in the panel.
Do you want, I can present it fast?
Yes, please share your screen with the case.
Okay, that will be great. Yeah.
Dr. Sen is tired since ECG.
Yeah, Dr. Kong, what time is there, Dr. Kong? I think it must be 1 o'clock or 1:30 there in the morning.
You have to unmute yourself. Dr. Kong, you're muted. You have to unmute
It's 12:30 and I've had my afternoon nap. I'm already in my pajamas.
But it's good that I'm able to say hello to Kong after very many months or maybe a year or two. That's nice to see him here. That's great.
Dr. Vijay, can you see my screen?
No. It's not there.
Okay. Can you see now?
Yes, you want to slideshow. I think it's there.
Yeah, okay. Is it okay?
Yeah, quite
okay.
Yes.
Am I audible?
Yeah, surely, sir.
Yeah, okay. So this is a 59-year-old female rheumatoid with bilateral severe protusio and severe knee involvements with fixed flexion deformity. She was bedridden for some years, obviously had osteoporosis, but there were no other comorbidities. She showed me in the OPD, I advised her hip replacements first and then maybe knee, because both the hips and both the knees were severely arthritic. Osteopenia was obviously there. And then patient got admitted for the left side THR. So if we can just ask one question to maybe Dr. Ramesh can answer. So in case hip and knee both are involved, which joint should be done first?
Usually we, as a standard, we go for the hip first and then subsequently go for the knee. It's a standard. Unless the knee is significantly deformed and requires better element, but as the standard says, because the hip is also likely to be affected, knee is likely to be affected in a rheumatoid kind of a condition. So it's better to get a hip first and then go knee.
And any special preoperative preparation other than the routine for any THR?
Now the problem is it's the deformity. So definitely depending on the kind of a deformity we will be dealing, and it's the kind of the quality of bone. Both these things are likely to make all our dilemmas. If we are looking at the fracture where we have got, if you are looking at the bone or the, depending on the joint concerned, we need to really define it out depending on the deformities, the releases which are concerned with the deformity. So if we are—
do you use PTH regularly in such cases?
Definitely so. And most of these we tend to use it.
So I reached the OT, patient was already under spinal and we were draping it. So we realized there's some deformity at the distal femur. So CM was used and we realized there's a comminuted very distal intercondylar fracture left femur while we were planning for THR left side. So this was in October 2015. So there was like 4 options at the moment, in the OT. We do ORIF and abandon the THR, or we just do a revision kind of primary TKR, or we do both. So finally, we did this. We did the ORIF. We asked for a plate and then we did a locking plate and finally decided to fix the fracture first. And because it was a sudden decision, not a planned one, so we wanted to preserve the bone stock, reduce the trauma, smaller implants could be used. And as a majorly trauma surgeon, we were more confident in dealing it with a plate rather than doing a revision kind of a knee. And this is the X-ray after the removal of the implant. And then we took this patient for TKR, and because it was osteoporotic and there were holes of the plate that we had removed, so we used a stem. And we had done a THR also, cemented THR. So maybe we can make out that there is a cement here of the THR coming up till this level, and the stem is extending this level. So we were worried that it may lead to interprosthetic fracture, but patient was fine for some one year or so. Immediate post-op X-ray. These were the bilateral cemented THRs that we did sequentially. The right TKR. So patient was full weight bearing, all the joints replaced. Patient fine, but again fell this year February, and this time it was an interprosthetic fracture left side. As Dr. Ramesh already told us, now it's a Vancouver type D, which was not earlier described, and it is more commonly seen in females. So treatment of interprosthetic fracture is challenging because the shorter is the bone capital, the free femoral shaft that we have. So more stress on any kind of osteosynthesis that we will be attempting. And usually it is dealt with a total femoral plating. Total femoral plating means the plate should extend directly from greater trochanter till down to the condyles. And the plate has to be stiffer and longer. Tangentially placed screws, cerclage wires, cables, bone grafts, strut grafts, and PTH maybe all have to be used. And other principles which can be used are used in different papers already illustrated in the long talks. Hcoated implants, stem cells, PRPs, BMPs, and sometimes, as I told you, replacement could have been done, but we were slightly hesitant, so we did the ORIF first, and improved screw fixation with using cements. So this is finally what we did. Because the cement was extending up to the fracture site, so we knew that with the cement in between the fracture fragments, it will not unite whatever we do. So we opened kind of ORIF we did, not a less. We opened the fracture fragments, removed some amount of cement from the fracture area so that there is some area where the bone will have union chances. We put in a lot of bone graft locally and then did this long locking plate with cerclage wires, and wherever we could put screws, we put screws. So total of 6 surgeries, but patient was mobile and pain-free. So open for discussion now.
Because we have seen that the fracture is united, but in this kind of a situation, the basic thing is that the vascularity of that area where the fracture has occurred is definitely at a very deficit. inside there is a cement, so you are not having a vascularity. The surrounding area remains, but that is taken care because you have to realign. So definitely, I personally tend to go, as I showed, that we must have a fixation as long as possible, going to the greater trochanter, coming down, because down there it was a simple implant, so that fixation had to be, that's the best thing which we could have done. And definitely, considering the viability, we could have added the graft, which has been done in this case also. So probably a longer plate with the good grafting around that area. If that bone would have been compromised, probably allograft, long slivers would have been the other way to support that area. But definitely, at many cases, just like I showed in one of the cases with a similar kind of a fracture pattern, that there was a gap, so I had to use a lot of graft over there and keep it with the mesh around it.
Right.
So these are the kind of the option which we can use in this kind of a situation.
Can I ask you a question, Harmesh?
Yes, sir.
Right. This is the cement was already set long back. I mean, that problem of cement not allowing the fracture to unite is in when which is a soft cement, it comes between the two bone surfaces. When this is already set there, I don't think if there's after a fracture, when you fix it, it will prohibit any kind of, any problem in bone union. Do you really, rather than removing the cement, you just can put lot of bone graft, as Dr. Ramesh has said, and that should be able to help us.
Sir, it's a very, I don't know, I don't have enough experience, but I personally thought that I will be putting graft inside the medullary canal also, and obviously around the fracture, which should have been done without removing the cement. But I felt that I have to give more biology for such a thing, because it was a very small fragment and with cement inside. So we could remove the cement, we could kind of slightly raw the ends and put in a lot of graft intramedullary as well as around the graft. So we felt slightly more sure, but I don't know what the evidence says. Maybe Dr. Ramesh or Dr. Kong can enlighten us with their views on this.
No, as I personally feel, inside the bone, that bone has also to get vascularity from somewhere. The graft has to work on some vascularity getting it from, and that will be from outside only. So maybe that we added a bone inside which can be incorporated from outside, giving a better strength. So that can be said as a positive point, because we provided a material for incorporation both inside and outside. So that way it could be helpful. Dr. Kong?
I think you don't have much real estate in the medullary cavity, even though you remove the cement. So as Dr. Agarwal says, the cement is already set. You got to make a big hole to put things out. I have always used the fibular allograft, and you can split it into two. You can get two, one medial side, one anterior cortex. Then you have your plate on the lateral cortex, and then you circlage them, or if possible, sometimes you can pass one screw to fix it. So the circlage with the allograft, long medial allograft that's almost as long as your plate, or half the length of your plate, has served very well, because you have to thicken the cortex in a way, rather than fill the medullary cavity with bone graft. It's more structurally sound.
Right.
Dr. Vijay, can we
Why do you
conclude?
prefer allograft? Why not autograft? Like the patient must be having his fibula. I think that will be better, no?
Yeah.
Or you always use allograft only?
The same patient bone. So and then you already have a total knee. You got another scar below. So I think allografts. I'm not sure it's very available in our setting, but maybe not so much in yours. But to get the patient's osteoporotic allograft, when you tighten the cables, they can actually crack, especially if you split them into two.
And what I have found it out, that if we are able to use the posterior iliac crest graft, there we can get a reasonably big slivers around that area. And these big slivers are very helpful in this kind of a situation. And especially when the patient, if you are able to position in the lateral position, so you can very easily get the graft from the posterior iliac spine. And that's a good
we
area.
took it from iliac crest, and a lot of graft was available, and we filled it really actually inside and all around also. So let's hope.
But as far as the bone loss is, and as Dr. Kong has said it about, the literature is clear about it, that we should use a long graft as a structural support in that area, because that is something which is... yeah.
Dr. Vijay?
Yes,
Dr.
sir.
Vijay, can we conclude now?
Yes, sir. Yes, sure. Thank you.
So I call upon Dr.
Hitesh, I think vote of thank. Okay.
Yeah, Dr. Hitesh.
Okay. Yeah, thank you,
Please,
Dr. Manish. That ends the part 2 of MIDCON, and it was a very nice MIDCON hosted by Dr. Rajesh Malhotra, Dr. Vijay, Dr. Kamran, and JPNNTC team. The topic was very pertinent, as in the time of lockdown, the incidence of fragility fractures is same. And I thank the international faculty, Dr. Koch, for staying for so long. Dr. Ramesh Sen, he had a hectic day today, marathon day, since morning, Vice President of IOA, and all the faculty, Dr. Kamran, Dr. Vijay, Dr. Ramesh Sen, Dr. Vivek, Dr. Balvinder, Dr. Maheshwari, and Dr. Amrish Mittal. So we traveled from medical to surgical treatment. We traveled from axial to appendicular skeleton today, and it was a very nice evidence-based discussion. And thank you all. And I just want to announce the quiz results which we had in the morning. And the first quiz for the PG quiz, first was Dr. Devansh Goyal and Dr. Namit R of AIMS. Second was Dr. Narottam Das and Ekjot Singh Arora from Safdarjung. And third was Dr. Apur and Dr. Rishi Madhan from AIMS. Thank you all. Thank you for a great academic.
Thank you very much.
Thanks,
Thank you,
Hitesh.
sir.
Thank you.
Thank you.
Thank you, Vijay Sharma.
Good night.
Thank you.
Very well done job.
Good night.
Congratulations.
To OrthoTV.
Thank you, everyone.
Thank you.
Dr. Sharad, thank you.
Okay.
Okay,
Dr.
good night,
Ashok
everybody.
Shah,
Good night.
can you
Yes.
stop the live stream, Dr. Ashok?
Yeah, I'll stop it.
Okay.